Bore da chroeso, good morning and welcome to today's Digital Health and Care Wales board meeting. As is our usual practice, the board is being held virtually, so people can listen live, and also you can catch up on the meeting after it's ended via our website. We have simultaneous translation available. If you wish to use that, if you hover over your screen and you see the series of icons across the bottom of the screen, you'll find one which looks like a globe called interpretation. If you click on that and select English, you'll get the interpretation throughout the whole meeting, and the icon will then change to a circle with EN in it. Okay, so we're scheduled to take one break during the morning, a 10-minute break. Depending on how things go, I'm hoping to take that after 5.2, and we're scheduled to conclude the meeting at 1:20 this afternoon. And of course, we'll be followed by our AGM later in the afternoon at 3 p.m. For just to quickly, I haven't had anything, I'm not aware of anything on the consent agenda, but if you do have anything, then please raise it and we'll try and slot it into the agenda. Apologies for absence. I've had apologies from Rowan Gardner for the entirety of the meeting. And Alistair Class-Neil has to leave at around about 11:15, and Alistair has some connectivity issues in that he's joining us from from continental Europe. So hopefully, if you do wish to say something, Alistair, the connection will work. If not, please put it in the chat, and I'll read out the question. Declarations of interest. I haven't had any so far. I can't see everyone at the moment because the holding screen hasn't come down. Folks, if you could take that down, I can see everyone then. Thank you. I haven't had any declarations of interest conveyed to me. Any occur to anyone since they've read the papers? No. Thank you all very much. If I then move on to the consent agenda, and I'll go through them, and please stop me and buy one if you wish. We're approving the minutes from the board meeting held on the 30th of May. People happy to do that? Q. We're approving the minutes from the extraordinary board meeting held on the 9th of July. And just note, and I think it's noted in the minutes now, that that though Ridian apologised, it was a Tuesday, which is a contracted clinical day for Ridian, so he could never have been at the meeting. So we're noting that, Ridian, so that it's obvious. We're noting that there are no actions on the action log. We're noting the forward work plan. We're noting our follow-up response to the Welsh Parliament, Welsh Senedd, Health and Social Care Committee and Public Accounts and Public Administration Committee scrutiny report, and we're approving the annual quality report. Thank you very much. If we move on then to the main agenda, and as always, the first item on the main agenda is the shared listening and learning presentation. And today we're going to hear about the Welsh nursing care record. We're joined by two colleagues who I'll let Ridian introduce. Over to you, Ridian. Yes.
I think thank you, Ridian. I think that the video does tell a good story, and I hope that I can be a voice for people who have dyslexia, ADD, neurodivergent, that technology really helps with, and really helps me fulfill my role as a nurse, without the barriers of the writing, feeling overwhelmed with all the documentation. You know, even simple things like it's in black and white and I can read it better than handwriting, or my handwriting is untidy. I haven't got to worry that people can see that my spelling isn't very good. So, you know, it's made such a difference to me. Thank you, no problem.
Marion, and then David.
Thank you, Chair.
Thank you, Marion. So I would say that and I can't say always, but 9 times out of 10, I don't leave clinical shifts late anymore. It's a maximum of half an hour, just tidying up bits as I go along. Whereas before, when I had the writing to do, I could be there till 9:30, 10 o'clock. And the feeling then you feel like you've just, you know, oh, here we go again. It just really, you know, impacts you that way. So I'd say at least an hour a day, you know, has been better spent, you know, that using WNCR.
Fran, if you want to come in on any point in terms of sort of, because obviously Joni's talking about her own personal experience, but you might want to come in on more general experience or more general issues around benefits or any questions that are raised. Yeah. So please do.
Yeah, and I think from my perspective, obviously this is Joni's story, but this is a story that's reiterated throughout when you go out and you stand there and you go out with the service users of what a difference is made. This is not the first time I've heard this story. I've heard it from multiple nurses on the wards, but I think that this became one of the unintended benefits of the Welsh Nursing Care Record, but actually in line with that, what that has brought the ability to do is for nursing staff across Wales to spend more time at the bedside, but actually real-time documentation, like Joni mentioned, that she would stay late to do the documentation. So one of the benefits of being able to articulate that is that the record is now up to date, real time, but actually that information is widely available to other clinical health professionals across the spectrum who are the multidisciplinary team that are also looking after the patient.
Good.
Thanks, Simon. Thanks, Joni and Fran. Thanks for sharing your story. It's really powerful. Thanks for sharing that with us. I've got a question. I'm not sure it's Fran to address, or it may be Sam, but this to me sounds like one of our success stories in terms of we've developed something that's actually quite powerful and it's been adopted by pretty much all of the health boards as far as I know. Do we have any funding behind it for the ongoing development to continue to improve and enhance what we provide to the nursing community?
I'm happy to come in there.
Go on, Fran. Go on.
Yeah. So yes, the funding now we get via SLA agreements, service level agreements with our health boards, and part of that is obviously within the Welsh Nursing Care Record. But in addition to that, when we implement new changes throughout, we have a business change team that are attached to the work programme who actually support our health boards to implement the new changes, update training materials. So it's very much as new enhancements, it's always about how we implement as well and support that service to do that.
Great, that's good to hear. Thanks, Fran.
Thank you, Helen, and then Ivan.
Thank you, Simon, and thank you, Johnny, and for coming to share your story with us today. And as Marion and David says, it's a really powerful story. And I suppose my question is related then to that, which is, what more do you think that we could be doing as the digital teams to support both from a nursing perspective and actually from an inclusion perspective? I guess it's for Johnny and for Fran, really, in terms of your reflections.
I think that the way that we're continuing the roadmap for WNCR, certainly from a nursing perspective, I think when we have everything on there, that will make a huge difference. And with the not just WNCR, but with the other programs, sort of e-prescribing, e-observations, I think digital certainly, and I've always been a real advocate for digital since I became a nurse, before I knew anything about DHCW. And in terms of inclusion, just keep us at the table, really, in the sort of design of things, because certainly my brain does work a little bit differently, and the way that I understand data does work a little bit differently. Not data, information does work a little bit differently. So just sort of, make sure that somebody's at the table during the discussions. I think that's the way forward.
Thank you. Fran, did you want to add anything?
Yeah, I think when I go out there and I listen to the exec nurses, for us as an organisation, it's potentially going harder and faster and getting the full suite of documentation out there, but also the inclusion of the wider multidisciplinary team and how we share that information more widely to the multidisciplinary team. Whilst at the same time, I do recognise when we do the standardisation, it does take time. However, what has really challenged the profession to do is really look at why we're documenting some items that are potentially not required. So that also can be a challenge, but I would be suggesting if we could get the full suite of documentation out quicker, that would be better, because the health boards run a risk of dual running of paper and digital.
Thanks, Fran. Ivan.
Thank you, Simon. I've got one comment and then a question following on. So the nursing system has been a major success. It's won awards. And so I think that it's worth our looking back at what the secret is, what's made it a success. And I think that one of the things is that we've spent a very long time working very, very closely with the nurses to standardize the forms that were used, so that, as Fran has just said, almost 200 different forms. Some of them were 60, 70 pages in length, all a little bit different from one organization to the other. And so I think that was the hard work, and up to 2,000 nurses contributed to the work of standardizing those forms before they were turned into digital forms. And I think that that was a really important thing, that we could agree on one method of working throughout the whole of Wales. And then secondly, after the system was provided, it was delivered in all organisations. So WNCR, there was a different one in Hywel Dda, in Swansea, in Cardiff. And the outcome of that was that the documents would stay within that system, and also that the process of putting new features in was slow, because the testing had to be done, the user acceptance testing had to be done separately in each of those organizations. And so by working with the users, they're really keen for there to be new exciting features earlier. So we've centered on one system across the whole of Wales. And because of that, the documentation, which is put in Ysbyty Gwynedd will be available in Morriston or in Cardiff immediately. And so there are tens of thousands of documents now that span across the regions. And I think that that also is the secret and the key actually to why this system has been so successful. So the question is, in addition to having more documents on WNCR, as Fran has just proposed, what's a question for Joni? What other systems do you use in the ward, and what other systems would you like to see working in the same way as the WNCR? Standardised across Wales so that you can see exactly what's going on and that the information is visible between one organisation and another.
Thank you, Ifan. With apologies, the meeting just dropped off just before you said on the ward. Sorry.
I'll just get on the preamble.
Please do.
Really like it, and they really like the working across Wales and the visibility of documents from and internal organisations. So, what are the systems that you would really like?
So we use Welsh Patient Administration System, and we use Welsh Portal. So they do work sort of hand in hand with WNCR, but have slightly different aspects. So for me, ultimately, I think it would be great if there was a combined, just a one sort of system for all, so that you didn't have to log into the different systems, that you had an oversight of the doctor's documentation and the multidisciplinary documentation and the results, so that you have got this overview, you know, filtered to what you need, obviously, but that's the kind of way forward that I personally would like to see. Whether that's the plan is a different matter, but yes, the whole logging on and having different systems can be a bit clunky sometimes, and you know, people don't know how to use one and know how to use the other, or the time switching between apps. But that's just my sort of ward-based observation.
Anything, Fran, did you want to come in?
Obviously, as a clinical professional, I would like to see all the same information, one point of access, and I think there should be one national system to enable that to happen, to be able to improve the safety and quality of patients. Because ultimately, at the end of the day, I am a citizen and a patient of Wales, and I want to make sure whenever I go into a health environment, they have access to all that information and that it's connected.
Thank you both. Marilyn.
I just want to say thank you very much, Joni, for sharing your story. Just, you mentioned earlier on about expanding it to the neurodiversity across the board. I just wondered what sort of steps were taken to widen it in relation to that, making sure that input is gathered within the development of the.
So I'm really sorry, neurodiversity coming out here. I don't quite understand.
So you talked about ADD, and then you also talked about your dyslexia, and you said in the video about looking at other areas of neurodiversity. So I'm just wondering how we're sort of encompassing that, how we're engaging with people.
Okay.
We're extending it across the neurodiversity platform.
Oh, okay. Yeah. So I mean, certainly, I've joined networks within my own health board that have been supportive. I mean, I can only speak from the perspective of someone with dyslexia, someone with ADD, of how it impacts and improves things for me. In my other role as a nurse specialist, so I work clinically once a week, and then I sort of go around the health board and I help to roll out WNCR and support staff. So within that, if somebody was to say to me, I'm dyslexic, you know, and they find that as a barrier, I can say, well, this is how it's helped me. So I can give them my experience and hope that then that supports them, and also signpost them maybe to the support networks that I found, because I was diagnosed quite late. So it's only now that I'm beginning this journey, and as I find different support networks, that's how I'm sharing them with others. I want other people to have the same sort of support. So I hope that's answered that for you.
Just
Someone said someone wants to come in then?
Fran, sorry.
Fran, yeah, go on, Fran.
Yeah, just really to say the whole programme has taken a multidisciplinary approach, but alongside the multidisciplinary approach, we've also approached patient forums as well to make sure that we are inclusive and diverse, and, you know, learn the lessons along the way. So currently at the moment, we're re-looking at the skin assessment, working with specialist areas and research from Leeds University for the inclusion of skin colour into our risk assessment tools, but also learning the lessons from that. We'll take that forward when we do new documentation. So we aim to be inclusive and diverse across the spectrum of the special needs of any service user and nurse throughout. So it is very much inclusive, but learning the lessons along the way to make changes where required.
Thanks, Fran. Sam.
Hi, thank you, and thank you for that presentation. It was from a user-centered design point of view. I can't get enough of those sort of presentations, because hearing from the user is also really important. So it's really just to touch on something that Marilyn talked about there. As you know, we are setting up our Centre of Excellence for User-Centered Design in DHCW, and we've already got around 40 people now working as a working group looking at this. And part of that is to embed that wider user-centered design across all that we do and all of our thinking. And I think there's one tenet that absolutely hangs true with this and completely supports what's Joni's message, and that is, if you don't build it with me, then you're not building it for me. And I think that's really important, and it's something that we need to make sure we strengthen that message across all of our developments, and especially as we start to widen that our user engagement and our user design and our end-to-end service design, which I think is what Fran and Joni are talking about when we look at how do we link all of our things together in a way that makes them make sense to the user. That has to be the absolute pinnacle of where we go. Well, actually, it's the pinnacle and it's the bedrock. It's both ends of the spectrum. So we absolutely have to embed that in everything we do, and that's certainly the direction we're going in DHCW now. And we've got we've got some brilliant people already thinking in this space. But it's stories like Joni's that absolutely spur people on to make sure that the job they do is the best job they can do for all the people that need to use the service. So thank you for sharing. Thanks,
Sam. Ridyard, I haven't got anyone else wants to come in. Is there anything you wanted to say before I thank Joni and Fran?
Other than to say thank you very much for the team putting that together, and for colleagues inviting guests coming and taking and fielding questions. So thank you.
Okay, Joni, thank you very much for taking time out to join us today. It's been very useful, very instructive, and I suppose on behalf of the board, glad that DHCW has made your life easier and your working life easier. So thank you very much for coming along, and Fran for joining us as well. Obviously, in your wider all Wales perspective is very helpful as well. Okay, so we'll move on then to the next item on the agenda. I'm getting a little bit of feedback. I don't know if other people are occasionally as well, so I'm not quite sure why that is, but I'm picking it up from a number of contributors. We'll have to live with it. Hopefully it'll sort itself out. So if I present the chair and vice chair report, and I'll ask Ruth if she's got anything she wants to particularly pick up on in a moment. There's a few everything is there for you to read in the report, but just to highlight, the board development meeting, our last one, which I think was great, that we went up to the mould office. I think the staff up there, as I understand, really appreciate the board taking the time out to visit. I think as a All Wales organisation, it's obviously important that that we do recognise that through taking the board into across Wales from time to time. And also I know, and I'll mention it in a moment, I had a one-to-one meeting with David Edwards, the chair, and he said how appreciative their executive team and their staff team were of the visit that our executive and staff team had made the day before to a number of areas of the organisation to look at IT, sort of the stuff that Joni was talking about, really what IT actually in operation and what impact it's having, and where it might go. So I think that was a time well spent. I've just mentioned I've been starting to have a series of meetings individually with chairs across Wales, and so I've met Jonathan Morgan from Cwmtaf, David Edwards at Betsy, and Ian Green, who's the chair of the new commissioning organisation, whose exact name escapes me completely, but it's what was the joint commissioning organisation, which has now been set up with Ian as the chair, and that's very useful in terms of us being able to go through specific issues that we have with individual health boards around how things are progressing and how they might progress, and also having a general conversation around the particular challenges that individual organisations are having at the moment. I'm currently in the process of establishing meetings with the remaining chairs. Hopefully, I'll get that through over the next couple of months. The other thing I draw attention to is the Digital Programme Chairs Network, which is a bringing together of those people who are chairing the programme boards, and they're obviously all Welsh Government appointees, but I was really keen to say hello to them and to recognise the important job they do with us and for us in terms of providing some expert and detailed advice and guidance on programmes and where programs are going and how they can ensure that, and it goes back to Sam Hall's point earlier on, is making sure that we get user involvement in our programs, and they form a very important part of that. And then finally, picking up on a few, you'll see that there were a number of performance meetings, both we had directly as an organisation with the Minister, myself and Helen, and then collectively with other NHS chairs and chief executives. And I think it was a useful opportunity to set out those things that are making it difficult for us to perhaps make the progress, the pace of progress that we would like to, and also to put a marker down that we all understand that money is very tight, but when there is no money available, then that makes it very difficult to develop new things and additional things. And we know there's a number of new and additional things that are really critical to the NHS in Wales that are need to be addressed sooner rather than later. So I think it was important that I was able to make the point that I understand why the responses or the view is there's no more money available, but the consequence of there being no money available is potentially quite serious. So that was useful for us to be able to set out the challenges that we face in doing everything that we would like to at the pace we would like to. I don't think there's anything else I particularly draw your attention to. Ruth, is there anything that you wanted to particularly highlight in your part of the report?
Thanks, Simon. Just that it was such a pleasure to present awards at the staff awards. And I know I speak for Marilyn Bryan Jones, who also presented an award on the night. But it was just really lovely to be there and to see the staff getting the recognition that they deserve. I'll give another shout out to the deserved winners of the Unsung Hero Awards, Rhys Bryant and Alex Lawrence, who won on the night the award that I presented. So yeah, I would highly recommend to any of my other non-exec colleagues that if you get the chance to go and present an award, it's absolutely fantastic. And then we followed that up by going up to North Wales to see lots of the award-winning primary care team, who definitely made the most noise on awards night. So it's been a good period of things which have been actually enjoyable and valuable for us in terms of staff engagement. So I just wanted to recognise that. Thank you.
Thanks, Ruth. Yeah, it was a great evening, the awards evening, for all sorts of reasons, both being able to recognise people's efforts and also bring people together. If anyone's got any comments or questions, please put your hand up. If not, I'll just ask you to receive and receive that report. Thank you very much. If I then move on to the next item, which is the Chief Executive's report, and hand over to Helen. Helen.
Thank you, Chair. And I'd echo yours and Ruth's kind of thoughts there on the excellent evening that we had for the staff awards. And yeah, it was a really lovely evening, and congratulations again to all of the award winners. So thoroughly enjoyed that. So just it's actually been quite a busy couple of months since we last met as a board, and we've been together quite a bit actually, as you say, with the North Wales trip in the middle. But a few things I just want to highlight, probably a couple more than I would normally pull out. I know you've got the report there, but just to kind of draw out a couple of things, just to formally acknowledge at the board, as we are all aware, that the organisation formally came under the Wellbeing of Future Generations Act from the end of June now. So we'll continue the work that we have been doing to kind of embed the Act across all of the work we do in DHCW, and do that through working closely with the Future Generations Commissioner's Office. Also, you'll note in the pack there's a link to our Compassionate Leadership Pledge. So I would urge you as a board to review that, and hopefully you'll be minded to endorse that and approve that at the end of my update. But really pleased to see us kind of bringing that to the fore, really, in terms of our commitment to bring our values to life, I guess, in terms of that Compassionate Leadership Pledge, which is a cause close to my heart, as I know you all appreciate. And then just picking up on the excellent trip that we had to North Wales, and the really valuable time spent with colleagues in BCU. So we were lucky enough to have an exec session where we got into some really kind of good discussions about kind of future strategy and some of the challenges, and how we can be supportive of one another as statutory organisations. So really helpful to work with Carol Shillabia, the Chief Exec there, and her team, and also to have the opportunity to do some of the clinical walk rounds and see some of the systems and services in place, both national and local, and kind of a reminder of that kind of the frontline kind of opportunities and challenges actually that are on a day-to-day basis. So thank you to the teams there for actually sparing the time, and in what was a very busy day, in fairness, for the clinical teams, and for their openness kind of in allowing us to be part of that. Also, we've been doing quite a lot on the leadership programme, as you'll be aware, colleagues, and we'll get more of an update on that next time in terms of the actions of the People in OD strategy. But really good that we've completed now our King's Fund leadership development programme for our senior leaders in the organisation, and that we've decided that actually this is something we want to continue in-house, and really focus in on those, making sure that we are creating that kind of team ethic across all of our senior leaders in DHCW. So really great that we kind of went through that process, and we are going to continue that. I've also had the opportunity to and it's quite difficult. We've had these conversations, Chair, haven't we, in terms of our ability to engage with staff as we're kind of in the type of organisation we are, and the level of hybrid working that we have. It's not the same as being able to drop into the canteen as we would kind of perhaps in a health board environment, and really kind of get the lowdown on what's going on. So I'm really pleased and thank colleagues across the organisation who joined me for a drop-in session, and I know the other members of the executive team have been running these as well. And actually it was great to have a cuppa and a biscuit, although I was on my fasting day, so I didn't eat the biscuits. But it was good that people did come in and really share, ask some questions. We had some good debates. We had some, some good private conversations as well. So I really valued it. So I expect us to be doing more of those going forward in the future, and urge colleagues across the organisation to come and have a cuppa and see me, other members of the exec team, and colleagues actually, to do that. I also want to call out and I'm not going to steal the thunder of Sam for later on, but the fantastic work that's gone on through the data centre to move, and we'll have the detail of that. But that took a huge undertaking for many members of teams across the organisation, with many weeks, months of out of hours, weekend working to actually make sure that we had a smooth transition. So just want to give our thanks really as a board to the wider organisation for that. And then just to pick up, we've had a joint executive team meeting with Judith Paget and her executive team recently. So a really good discussion. It was our year-end review where we reflected back and look forward to this current year. And we have recently received our escalation, we reinforced our escalation status as routine monitoring as a consequence of the review of that. So yeah, just happy to take any questions on that, but it's been quite a busy couple of months, Chair.
Thank you, Helen. Just before any questions, because there's a specific item to approve in your report, which is the signing of the Compassionate Leadership Pledge. Has anyone got any questions or comments on that? Because before moving on to more general questions, I'll ask people if they're happy to. Hopefully they are. Okay, are people happy to approve the signing of that pledge? Lovely. Okay, any questions or comments on Helen's report? No, thank you very much, Helen. I'll receive your report, and we move then on to the next section of the agenda, the strategic items. And the first one we're taking, item 5.1, is the primary care strategy action plan update, and that will be Sam Hall who is going to introduce the item. Over to you, Sam.
Thank you, Chair. So I was just going to give an update on where we are with our action plan for the primary care strategy that we brought to you. I think it was towards the end of the last calendar year. So we have identified leads for all of the primary delivery areas, and they're getting to grips with fleshing out what that actually means for delivery in those key areas. And the full plan is being drafted over the summer. And what we're having to do is take into account the exceptional set of circumstances currently in the primary care space, with things like the rollout of the NHS Wales app, the much anticipated move to electronic prescribing, and of course the transition to a single GP system supplier of almost 200 practices across Wales. My teams were able to present that full range of those rollouts to the board at the meeting we mentioned in Mould last month, and I know how impactful that session was on all of us that were listening to just exactly what was having to be done to get those things moving and to make them work across the primary care piece. So whilst we really want to push on with our delivery, and obviously we want to move things as fast as we can, we're mindful that the teams are under pressure as they support this work, but also our GP practices are having to make changes and adapt, whilst at the same time dealing with incredibly high volumes of work. So we are being very mindful and respectful of that. That said, we still know there's a lot of work to do, so we are pushing on. Our directorate is, and actually the wider organisation is also going through some changes to establish a more product-focused, user-centred structure, which better lends itself to delivery of the strategy objectives. So actually, for us, the timing is right that those changes are happening and things are moving at an organisational level as well, and that's helped us to really solidify our thinking around, especially around the user-centred design work and how we better engage with our clinical workforce out there in the wider NHS. So with that in mind, we've already started adopting the strategy through our current working model, making sure we're delivering through the user-centred design approach. And a really good example of that actually is evidenced in the dental access portal work, which was a ministerial priority to create effectively a full waiting list of people waiting for NHS dentists across Wales. And the work we have done around that has been very much user-centred. So this needs to support not only our health boards to be able to use the portal to allocate people to an NHS dentist as space arrives, but also for members of the public to be able to add themselves onto that list when they need a dentist. So that is currently in pilot stage, and it's in pilot in Powys, but will be rolled out further in September, and the full rollout will be in November. But we are completely ensuring that we are putting that user feedback back into every stage of that development of that project. And also we've started to look at our Choose Pharmacy product, which we know is hugely successful and a great benefit to primary care. But actually it's been around a long time and it needs a redesign. So we're applying a full end-to-end service design of that product to look at how it fits into the wider space. And we're taking, and so we're supported on that journey by our lead pharmacy clinician that's come into the organisation, and Kath, who has been really helpful in making the links for us with the people and with the users who are able to influence what that design needs to look like for the future. We've been also supporting, a lot of people think of primary care and they automatically think to GPs, but obviously it's dentists, but also alongside that is our community optoms as well. And we've been rolling out, and we're due to finish that rollout this summer, of NHS 0365 licenses to those optoms that work out in the community. And part of that is to bring them more into the fold into the NHS so they can start accessing services as well. And that is part of the wider piece of work, again, around the service design, to have that whole primary through to secondary care system set up. So while it's one step on the rung to do that, it is, again, part of that end-to-end service design that we need to really start to push forward as our primary care strategy moves forward. The work being done to successfully transition the electronic prescribing program work into business usual for primary care has really shown us the importance, and one of the strands that came out very strongly in the strategy was how we land things with users. So, we work with them to develop it, but actually when we land it and we hand it over and it becomes business as usual, the real effort we need to put in then to continue to support through that transition into making that thing live and business as usual. We're finding the feedback that we're getting and where we can make tweaks and changes to how we do that through the electronic prescribing program has been really helpful, because that impacts GPs and pharmacies. And so we need to make sure that those links are really strong, and we are there when they need us to be there for that transition. And another, as it mentions in the paperwork that we supplied for this, is around the kind of clinical engagement and making sure we have a real focus on that clinical leadership. And one of the, I can't actually put enough emphasis on how important and how impactful this has been, but the agreement with Ridian to move the 2 AMDs that work in the organisation into the primary care fold more fully, so that they work with the primary care teams. It's increased our clinical engagement and no end. We are now able to get into a space where we have digital leadership and clinical leadership at the right level, where we can have the right conversations, and that has had just been hugely beneficial, not only for the conversations we have, but also for my teams and the access they now have to the 2 AMDs that we have, so much so that we've increased how long they work with us. So they are GPs, they work out in GP practices, and we've increased it, so we actually have one every day working with us, so across the 5 days of the week, and that's been amazing. So just to recap, there's an awful lot of work going on. We're still compiling what that delivery will look like. We're working with a strategic program for primary care to make sure that we are also hitting the right elements of the more strategic and national requirements around primary care. But that doesn't mean we stopped, and we are already embedding in everything that came through that strategy into what we're doing now. So whilst we're looking for new initiatives and looking for the future, we're also already embedding those principles and those priorities within what we're doing now. And I'm incredibly proud of the primary care team for how they have really grabbed this, run with it, changed their approach to how they work. And I'm very confident that we will have some very successful outcomes because of their approach to how they want to deliver in the future. Thank you.
Thank you very much, Sam. And obviously, I'm sure people would want to echo the appreciation for the huge amount of work that the team are doing at the moment and the huge amount of work they've got in front of them. Ruth wants to come in, and then David.
Thanks, Sam, and thank you for the update. I know we regularly speak about all things primary care, and I think particularly over the last 18 months, there's been, for me, a real difference in the clarity of what we've got in our portfolio and being able to get our hands around that and articulate it in a much clearer way. And great credit goes to your team, but great credit goes to you as well for grabbing hold of that. So first up, I wanted to say thank you. My question is on clinical engagement. Partly I ask this because I know that it's something that Rowan, who's not here today, is really conscious of. One of the things that I think we've struggled with in the past is that either we have been driven by the clinician view completely without any reference to the technical aspects of what's happening within a product or service, or we haven't had enough clinical engagement. This feels like it's going some way to bridge the gap, but I just wonder what more there is that we could be doing across the portfolio to be able to translate that technical requirements piece into the clinical world and vice versa. And I wonder if perhaps Ridian might want to be able to comment on that as well. Thank you.
Do you want to pick that up now, Sam?
Yeah, I can pick that up quickly. I completely agree. We haven't, certainly in the primary care space, we haven't had enough engagement at that level. And if I could, I would have a pretty much a full-time dentist and an optom and everyone else across that in the team, because they make such a huge difference to the way we think of things. We're very digitally minded organization, and we should be. That's the title, and that's what we do. But actually the grounding of people who do the job, that whole, you're building it for me, you're building these things for people like me. And when I leave DHCW at the end of today, tomorrow I'll be using that thing that you tell me is brilliant. And I'm going to tell you it's not so brilliant. And I think that as much as we can do to include that alongside the digital voice, which is hugely, the digital voice will help cut through some of the I want and get to the I needs. And that again is also the critical thing. As you said, sometimes when we talk to a lot of clinicians, we'll get a lot of opinion, and we have to really cut through that. And part of that is also, training with our teams to help them to really, elicit the right information out of people, get the right information to get to those needs, and deliver on the things that absolutely will make the job better and easier and safer to do, as opposed to the opinion, which, as we all know, everyone's got one.
Ridian, did you want to come in as well?
Yes, I would like to make a comment. So first of all, the expansion of the clinical voice within our own organisation, the appointment of a chief pharmacy information officer. We obviously have a nursing information officer. We're going out to advert for an AHP, so allied health professional, to provide that. So building some internal expertise. And then my other comment would be the engagement with the NHS executive. The NHS executive has recently appointed a number of clinical leads across certain specialties and paid them in a way that they have released time to engage in this agenda. Previously, we've had best endeavours, and colleagues will know that when a clinician comes and does something for us, their clinical work doesn't go away. So it's really positive that the NHS exec have done that. Some health boards have now gone further with their chief information officers and their medical information officers by giving them even more time to lead. CumTAP are leading the way there. So there seems to be a general direction of understanding the importance of having a clinical voice around the table.
Thank you, Ridian. I got quite a few hands up, so I'll go to take a couple and then come back to you, Sam, and then take a couple more and come back to you. So David and Chris first.
Thanks, Simon. Thanks, Sam. Sam, great update. Lots of progress being made in the right direction. So well done on what you've achieved so far. I've got a couple of questions related to the dental access portal that you mentioned. The first is, do you envisage that members of the public will be able to add their name to the list if they're seeking NHS practice to do work? First question. And secondly, do we have funding in place to roll this out across all of Wales?
Chris.
Thanks, Simon. Yeah, just wanted to echo Ruth's comments. Well done to Sam. I think within a year of joining, we had a primary care strategy within a brand new directorate across the organisation, and there's a clear vision there, isn't there, for the directorate? So my question's linked to that. The update talks about the importance of aligning the target operating model to the strategy and vice versa. So I just wanted to ask Sam, have there been any concerns around the target operating model or any initial feedback? Are you having to change anything from your original plan?
Okay, Sam, do you want to pick up on those three questions there, really, I think?
Yeah, sure. So thanks, David, on the DAP question. Yes, members of the public will be able to add themselves to the waiting list. They will also be able to add their family, and they will also be able to add someone that they care for. So it'll be the full range of access. So the health boards will use it to allocate, but members of the public can add their names to the waiting list. And that functionality will go live in the next sprint, actually. So it's already there, but it'll be rolled out wider. And as funding in place, we've got funding in place for this year. So we definitely need to, as we're going through the development and the bedding in and the rollout and all of the testing and training around that, we need to work out what it's going to cost to run properly and to keep improving it, because that's the other thing as well, is that it's continuous improvement. So how will we make that better, and how will we continue to make the service better? So we need to look at what that will look like once we've delivered the full product. But for now, it's funded.
And then Chris's question.
And yeah, Chris's question. So the target operating model, as we move to the product, I think what we've had to do is do a lot of work to understand what are our main products and services in primary care, and which ones that we have control over and which ones we don't have that much control over because they're supplier led. So whereas in a target operating model for a fully software development type house, it's really clear. In our organization, it's slightly different. So we've had to work out slightly different roles. They all fit within the DDAP++ spectrum. And actually we've moved, and we've done a lot of work with Sarah Jane's team to move that work on. But actually we have found that all of our people and throughout the whole team all fit within the new structure. We won't lose any people. There'll be some really good training opportunities and some career opportunities in there. But actually, the work is still the work. It's how we approach the work that changes. And the culture around embedding that continuous improvement, the users at the center of everything, the clinical engagement into that delivery, that doesn't derail the work that we do. It will still be there. But the approach is where we really get the benefit and we really see that impact. And from a staff point of view, as we're going through OCP, I can't talk about it too much at the moment, but the levels to which we've engaged with have been hugely engaging. And you know, we've had some brilliant challenge and also some great enthusiasm. So I'm really confident that we're going in the right direction with that. Absolutely.
Thank you, Sam. And then I'll take Alistair and Marion and then come back to you again, Sam.
Thanks, Simon. First of all, check, can you hear me?
Yes.
Brilliant. And thanks also for the update, Sam. Really good to see the progress being made. The tendency is for us to think of primary care in the NHS context. I would argue quite strongly that schools are primary care for young people, and that they have certainly a significant role in it. And I'm connecting this with the other part, one of the other parts of your teams and your own role, Sam, in terms of communities. I just wonder, given the importance of dental health, especially starting with early years, is there more that we can do to connect with nurseries and schools, particularly primary, but also secondary, to support daytime toothbrushing, to develop the good practice and the habit. And this may not require new funding, but new focus and certainly local timetabling changes. I've popped the question in the chat in case that's broken down. Thank you.
No, we got all of that. Alistair, Marion, and then come back to you, Sam.
Thank you, Chair. And thank you, Sam, for that update. It's fantastic to see so much various work going on in this really important area. My question follows David's comment actually on the dental service and the pilot scheme that's going on in this area. And the question really is, the pilot will define the demand in due course that exists for dental services across Wales. But we know that there is a huge shortage of dentists. How do you therefore see this data that we will be collating influencing our ability, or how it'll influence Welsh Government to be able to provide dentist services more effectively across Wales?
Yeah, it's an interesting point that, Marion, because unless I'm wrong, I mean, what we're doing is helps quantify demand and access to demand, but it doesn't actually solve the problem of meeting demand, unless I'm wrong, Sam.
No, you're not wrong, Simon, not at all. I'll just pick up Alistair's, and I can pick it up really quickly because I don't have the answer, so that's really quick. So where it comes to the school context, I think one of the things that around the digital access portal that we are looking to do, and one of the reasons for doing actually, is to be able to look at the priority within the waiting list. And so it's really key that as we look at the waiting list, we will know the types of people that are on it. And one of the reasons for that is to be able to address the childhood dentistry issue. So that will be able to identify the number of children waiting for NHS dentists. And so at least those people that do go out into the schools and are leading on that work around, good oral health, which is hugely important, will at least have more powerful information rather than just being able necessarily to go into schools. They will know where there are areas of most concern. And I think that is where we as DHCW massively lend our power. It's the power of the data and the digital tool. It's not the power of the toothbrush. So I think, we are in our lane and we're doing all we can in our lane. And, the better we can make that data, the better we can make the demography, the better they'll be able to really impact that change in schools. So, yes, I didn't really have that much more I can add because I don't know the background behind how the toothbrushing in schools works, but we're doing what we can in our space. And so yes, I think to answer Marion's question, the digital access portal is not going to create more dentists, and that is that is the bottom line. We're not going to magic up more dentists, but what we will be able to do is actually have the most comprehensive waiting list that we've got. So the current situation is you might have a health board with a waiting list, but actually every other person that's trying to get on a waiting list has been ringing around all of their local dentists, potentially in some areas up to 50 miles away, to get on a waiting list. And so there are lots of double entries, there are lots of people that are on multiple waiting lists. So we don't necessarily have clarity of how bad that waiting list is, which makes it really difficult for Welsh Government to plan how many dentists it needs, because we don't know how much sense there is in that waiting list and the actual numbers. And we also don't know the priority within that waiting list. So how many children are there? How many elderly people are there? How many people with existing conditions are there? So I think being able to do this, for me, it feels like it's a strange thing. It's a waiting list, essentially, but the power of the data behind that waiting list becomes really, really incredible. And you, as you know, we have discussed before, there are areas across Wales where this is a real problem, much more so in some areas, and you know, your neck of the woods is particularly impacted by lack of NHS dentists. So it also gives us the power to see, where do we need to put people? Where is it that we need to encourage more dentistry? Where is it that we need to shore up the system to be able to take people off this list? So I think that we are doing what we're good at doing, which is the digital and data bit. And this really showcases the power of national digital systems delivered in a user-centered way. And I think that is going to be a very I think this is going to be really impactful for something which actually feels quite a small thing to do. But believe me, the work behind it has been incredible. So sadly, no more dentists, but at least we'll know where they're needed.
Thank you, Sam, and thank you for your update. I don't think there's any other questions or comments. We've been asked to note the update and also recognize again the huge amount of work that goes on in your neck of the woods, Sam. And we know that you've got some particularly what's the best word? Interesting pieces of work that you're leading on in your team. So we thank you for all the effort that's going in and the results that you're having.
Thank you. If
we move on then to the next item, the strategic procurement report, and I'll ask Claire to the Exec Director of Finance to introduce the item. Claire, over to you.
Thank you, Chair. So in compliance with our standing financial instructions, any procurement with a value over £750,000 has to come to the board for approval. So what I'm going to talk you through today is one application for approval. This, given the value, has been sent to Welsh Government for notification, and we're still awaiting that. So today's approval would be subject to the Welsh Government notification. And the approval is it's part of our libraries aspects of DHCW. It's for medicines information and a drug tool. It would be coming into effect from the 1st of September, and it is a 3-year contract. The total value of that, excluding VAT, is £2,154,995, and it does have an option to extend for 2 years. This information and drug tool is used daily by pharmacists and clinicians across Wales, and it really helps to inform diagnostic and treatment decisions. This particular procurement extends the scope of what is offered in that, and it extends to palliative care. It also extends to critical care, and it also helps underpin some mental health pathways, giving access to psychotropic drug directory. So there is an extension in relation to the offering of that particular functionality. And not only does it offer the additional functionality, it does also give support in terms of training, maintenance, and the implementation of this tool. It is more expensive than the previous tool. It is a cost pressure, and the National E-Library Service Board, together with the library champions, have identified areas of savings to mitigate this cost pressure. And that involves turning off some functionality, but also rationalisation of some of the journals in order to mitigate that cost pressure that this particular procurement will facilitate. It has been approved by the National E-Library Service Board, and the procurement was overseen by the E-Library champions. So I would like to therefore ask the board to consider this particular procurement and approve it. So I'm happy to take any questions.
Thank you, Claire. Anyone got any questions or comments on this one? David?
Thanks, Simon. Thanks, Claire. So happy to approve, Claire. I've got no issue with it. But I've got a question which is probably best directed to Ridian, which is, this is quite a powerful database that's used at the moment, presumably in isolation. When we've done our digital transformation program and we've got e-prescribing, is there any plan to integrate the two? So the system, the electronic prescribing system has access to this so that it's done online rather than having to look at two different systems?
I'll come in then. Good question, David. As you're aware, the EPMA program, there are essentially 3 suppliers on the framework. They all have clinical decision support tools built in within their digital interfaces. All of them are different. The actual underlying evidence that those clinical decision tools rely on comes from databases such as the one that we're discussing now. The current provider, the digital version of that, isn't in the workflow. It is a reference database.
Does that answer your question, David?
It does. I would have thought it was more powerful and would avoid patient potential risk if it was integrated in the workflow, but I guess that's not in scope at the moment, is it?
It's not within the power of Digital Healthcare Wales to integrate it with the commercial providers of different EPMA systems. What we do have the power to do is to put it on every single clinician's, pharmacist desktop, so that it's available for reference. This is we might think of this as sort of replacing the type of paper BNF directory of medicines in a more dynamic way that provides clearer identification of contraindications, relative cautions, and some clinical advice associated with drugs that might be, for example, nephrotoxic, harmful to the kidney, etc. As you're aware, clinicians prescribe and others dispense and check. There's a 2-point check to that. So the pharmacy community are particularly dependent on the reference data provided by such provisions as the one we're discussing.
Okay, thanks, Radin.
Thank you, Claire. People happy to approve the procurement? Yep, lovely. Okay, we'll take a break now. It's just coming up to 11:15, so can we reconvene at 25 past? That's a 10-minute break. And remember to turn your cameras off and your microphones off. Thank you. See you in 10 minutes. Okay, we're just waiting for a few people. Here they come.
Chair, could I just ask, does that sound better?
A little bit, Ridin, yeah, definitely a little bit clearer. Doesn't sound like you're talking through a sock now, anyway. Or as Sam would say, talking while brushing your teeth. Okay. Sam Lloyd, just Andrew. Okay, I'm sure Andrew will be with us in a second. Okay, thank you. Welcome back, everyone. And I'll hand straight over to Claire to introduce the finance report. Claire.
Thank you, Chair. And I can't believe we're at the end of the first quarter of 2024-25. Doesn't time fly? So I hope Jenny's going to flip up some slides for me. And I'll briefly talk you through the Q1 results and where we are in terms of some of our strengths and weaknesses. So Jenny, if you skip us on a couple of slides and the next one. So as you're aware, we have funding predominantly through Welsh Government, through our core, but also through our DPIF, and I'll take you through some of the outcomes of that spend in terms of Q1. So if you move us on to the next slide, Jenny. Okay, in terms of the summary, obviously this afternoon we'll have our AGM where we finally present our financial position for last year. I was delighted by the recent audit committee and the presentation of the annual accounts for DHCW, which are unqualified, and actually the process has run a lot more smoothly this year, and we balanced our accounts, which was amazing. So I'd like to take this opportunity to thank my team who've worked hard underpinning that, and at the same time pulling together the budget and the results for this financial year. The full year forecast position as at the end of Q1 is that we will achieve our statutory requirements and our financial targets for the financial year. I will take you through a summary of where we are at. I will also talk about the run rate, which looks at our actual spend versus our projected spend in relation to pay and non-pay, and look at the variations across the months and some of the reasons for that. So there were some big milestones in the vaccines and TTP in the quarter, where we finally ceased the track and trace requirements and stabilised the data and put them into a safe holding in the NDR. And also the vaccine developments are progressing well, and you'll see some of that spend come out in the results. Savings, which I know is as hard, particularly in the recurrent nature. You will see our savings projection. We are ahead of plan, albeit that is dominated by vacancy, which is obviously non-recurrent. So we've got some work to do in terms of building our future and really looking at our future configuration and what opportunities that creates in terms of sustainable funding and finances. This is a big month for us in June and July. So you'll see our cash position shift up significantly as we procure the annual Office 365 contract. And again, working alongside our partners across health boards and trusts, that has gone extremely well with all health boards settling their bills in a timely manner, which was really helpful. In relation to the DPIF programmes, towards the end of the month of the quarter, we did receive final notification from the funding from Welsh Government in relation to DPIF, and the overall funding was in line with expectations. In fact, we had some additional funding, which I'll touch on in the DPIF section. Again, that was qualified, so they gave us a criteria around the 30% withholding Q4. We're working alongside that because, as in previous years, DPIF funding is agile. It really is heavily dependent on contractual and health boards deliveries, and we're working with them to find a happy medium there to, as we have done in previous years, to find the right balance and funding requirements, and we've put a proposal in terms of how we will do that. Our capital plan is progressing a little bit slower than we would have expected. It is very much back end loaded, but again, I'll show you what our plans are in relation to that. And we have identified a couple of risks, but also some opportunities financially. And again, a lot of work in that space during the quarter to try and minimise that effect, not just for DHCW, but for NHS Wales. So I'll move on to the first slide, which really summarises us from a financial perspective of where we are against our statutory requirements. We were slightly under plan at the end of the quarter. We have £46,000 behind plan at the end of the quarter, but I'll show you where the gains and losses were in relation to that revenue spend. Our capital was broadly in line with what we'd expect in terms of our DPIF funding at the end of the quarter. And our public sector pay policy was above target, but you'll see there our cash balances were particularly high at the end of June, and that's really as we would expect with that significant payment going out in July. So let's have a look at where the revenue spend looks like through the DHCW Directorate lens. So if you move to the next slide. This slide really just shows you can see the green box of 46, that's our underspend at the end of the quarter. The blue boxes show you the underspends by directorate across the organisation, and you'll notice two red bars. And those reds are the areas where we've seen particular cost pressures in the first quarter. No surprise for operations, as you'll hear in a later presentation. They have had some they've finalised their data centre move and have had some particular advice around networks, which has pushed that directorate slightly adverse to plan at the end of the quarter. And equally, workforce was slightly worse than plan. I'm not sure that was a deciding factor in the move of our pod and OD director. But that said, again, there was no risk in either of those. It was anticipated we'd see some of those pressures, and I think for both we'll see those pressures go into Q2, but they are aiming to recover those positions by the end of the year. So if you move us on to the next slide, this rally then looks at our run rate, and obviously throughout NHS this is really a challenging time financially. And it's really important we demonstrate grip and control around our run rates, our spend and our transactions. And we have, within DHCW, we do that through our budget holders. We have a group of budget holders across the directorates that own and direct the spend. But equally, we review this with the directorate leads at their SLTs. So this really demonstrates what we anticipate our spend profile to look like going forward. You'll see the non-pay, and it's not dislike previous years, does fluctuate. And that really reflects the fluctuations in spend profiles associated primarily with our DPIF requirements. And again, we've highlighted a few of those variations across the forthcoming quarters. And also in terms of our dark blue, which is our pay, we are recruiting, and the numbers within DHCW are going up. But again, that is forecast, and obviously that will enable us to balance our books at the end of the year. So I'll move us on to the next slide that then ventures into the Digital Priorities Investment Fund, and this is getting quite busy. So apologies for that. This details the £28 million that we identified at the start of the year. You'll see it's gone up. We've had an additional £1.65 million worth of allocation as part of a recent notification from Welsh Government. And that really is for two areas. One is the Child Health Red Book discovery work that Sam Hall will be leading within primary care. And equally then there are additional funding related to the NHS app, which is really focusing on secondary care and improvements in secondary care. So it was we saw those in the month, but as you can see, we haven't actually planned or profiled the spend of those as yet, and those will come in the next quarter. Notably though, in terms of the DPIF spend, the 28 million, there is some variations, and you'll see that reflected in the milestones delivery. So there are some areas where people are ahead in terms of their spend, And there are some areas such as NDR and maternity where we're slightly behind. Nothing material in value, but again, it's an area that we will keep our eye on going forward. But as you can see, at the 25% through the year, and we've still got 73% left to spend. At the bottom, we've got the NHS Wales funded scheme. So this is money that's come to us from NHS health boards and trusts predominantly, that also supplement the development spend that we get directly from Welsh Government. And again, progress broadly in line with what we would expect at this point in time. And I suppose notable there is the fact that we are spending, supporting the intensive care unit revenue currently. And again, as we go into the second quarter and get greater clarity on the expectations there, then that will become clearer in terms of where we're going in terms of that spend. Okay, so I'm going to move us on to the next slide, which looks at our capital spend, split into two. So the top half is our discretionary spend, and as part of our board development and also the building our future work, we are focusing on our ground floor within T Glanner Avon, and again we plan to spend that, and work is progressing well in relation to that. In terms of our infrastructure and comms, Sam Lloyd, together with the team, are looking at the priorities, and again, towards the end of Q2 and into Q3, we'll have you'll see some of that spend really start to kick up as the procurement starts around some of those key aspects. Our digital priority investment funds, again, dominated by Lincoln RISP, and as you can see, the spend profiles are already starting to show themselves in the accounts. Again, the rollout of those programs will influence the rate of the spend within those capital areas, and working closely with the programs, we will reflect that in the accounts going forward. So those are the capital spend. I'll move us on to the next one, which is in relation to our savings plan, which, as you can see, cumulatively is dominated by vacancy management, which is currently 690,000 and ahead of plan, and it's really influencing the savings being ahead of plan by 326. So this is again, as you can see, that the gains have reduced significantly since April, and there we are starting to see recruitment and work packages come in to mitigate some of those going forward. The key thing in this is really understanding going forward, as part of our building the future, how we look to deliver recurrent savings in both the non-pay and pay areas in order to maintain the £1.6 million worth of a recurrent requirement going forward from DHCW. So this will be an area of focus for us in Q2 and Q3. Okay, if I move us on then to some of the risks and some of the opportunities. Notably, we are still seeing pockets of inflation, and particularly around some of our licenses, and it's not just DHCW, it's across the system. So working with the directors of digital, we are looking to mitigate those as a national in national procurement, and we've made quite some progress in addressing those in the quarter. So we've mitigated a significant financial pressure, digital pressure in Q1, and obviously that will fall into the procurement plan for Q2, and we need to crystallise that. But it still remains a threat, and I think it's worth noting, you know, as we go through the year and as procurement re-procurement takes place, it'll be interesting to see quite how this will pan out as the year progresses. And DPIF funding, as I've already pointed out, we've received formal notification of our allocation for this year, albeit we've received confirmation of 70%, with the 30% being profiled in the last quarter, subject to delivery of milestones. Given the interdependencies with commercial health boards and other programmes, and working alongside Welsh Government to come up with a means of being able to work in an agile way for the remaining 30%, and I'll report back progress of that as and when we finalise it. The opportunities for us remain. We are working again to look as part of our joint brief with Welsh Government at how we build a sustainable funding model for DHCW. We are raising the profile. We've already submitted the NHS app requirements for future funding, but with the NDR and cancer informatics a priority, those will really need to be finalised as we go into Q3 of this financial year. We haven't given up on the VAT. For Microsoft, we had a meeting yesterday. It has moved from a technical review to a policy review. And again, we are working with our advisors to try and understand what our options are within this going forward. And again, in September, October, we'll have a greater understanding of what options we've got in that space. And finally, but this is probably really important going forward, we need to find more value, more recurrent value. So as part of the transformational programme led by the senior executives of the team, we are really getting underneath what our new operating model looks like, what we can do to simplify our architecture and become more efficient, and what that will mean in terms of the contribution to our savings requirement. And that is certainly stepping up pace and has done during June. And then finally, to the last slide, which basically says, I'm asking the board to note the formal funding letters of Welsh Government and the conditional criteria set within it, but also to note the position at the end of Q1 and our forecast that we will achieve our statutory requirements for the end of this financial year. And I'm happy to take any questions, Simon.
Thank you, Claire. If you could take down the slide so I can see everyone. Thank you. Okay, questions, comments. Sam. Then David.
Sorry, just one, Claire. When you mentioned digital inflation, do we have any idea of what that is going to look like, or what that might be? Is there any kind of learned work going on the anticipation for it? Because obviously, reading things in the digital world, you see about people having to make allowances and add things into their bills, etc., for things like covering extra cyber threats and other elements that I'm sure will get played out in the work that we're doing as well, and the bills we're paying. So just wondered if there is any thoughts around what that might start to look like.
So it's really difficult to predict. So if I looked at the example, we were working closely with Sam Lloyd during Q1. The increases were materially significant. So you're talking, it was about 400% increase in our licence arrangement, which was millions of pounds potentially for NHS Wales, and not just DHCW across the system. There are changes in the ownership of some of the licensing houses and some of the software companies, and that's really difficult to predict. But what we are doing together with the commercial team is producing a roadmap now that looks at licensing and the forecast relicensing, and trying to work alongside Sam's team to really look at how we can mitigate or work at a national level to try and have some influence over what those price increases will be. So yeah, it's a constant threat, and it's one of those ones which is really difficult to fully predict. But again, it's for us, isn't it, to keep our nose to the ground and also work with our colleagues across the system to work out where those risks sit and what we can do to mitigate them, I'm afraid. So
thank you. David.
Thanks, Simon. Thanks for the update, Claire. I've got two questions. The first is related to the ongoing savings we're making through the staff vacancies, which is great for balancing the budget. But I'm just a little bit concerned about our ability to deliver on the commitments if we don't have all the staff we need. So might be better directed at Sam in terms of a response, but please feel free to answer. And then the second question is related to the eye care programme. Great that we've managed to secure some funding for that. I think it sounds less than we need to do the full deployment. So I'm just wondering what the 300k that we've managed to secure will actually allow us to achieve this coming year.
Can I just add a flip side of the coin to David's first question? And you know the question I'm going to ask, because I ask it, I'm trying to make it every time, but it's important that it's made. We're now entering our 4th financial year. Each of the 3 years we've had, we've achieved savings targets on the basis of non-recurrent vacancy management. I'm sorry if I missed the figure, but where are we now in terms of the baked in non-recurrent deficit that at some point is there? It's a real thing, because if we reach a point where we fill every vacancy, then that's the figure we're left with. So what, I apologize I've missed it, Claire, but where are we in terms of the, and if you don't have it to hand now, don't worry, but I think we need to be cited on it as we go into this year. So that's it's the flip side of David's first question.
Yeah, so you're damned if you do, damned if you don't. So in terms of the impact on vacancies on our ability to deliver our milestones, I think, if truth be known, if you look at where the vacancies sit, we aren't seeing that impact yet, in terms of, because most of those vacancies sit within primary care and in that area. So actually, if you look at Sam's ability to deliver her milestones, actually she's doing pretty well, despite the fact that those positions are there. Having said that, though, over the next quarters, Sam's work steps up. She's put a number of work packages in to mitigate some of that, and they're going through the system as we speak. But if you look at other areas, we have had to adapt our milestones to reflect the fact that the DPIF funding actually did come down this year to 28. So when we've done the funding, we've actually looked at reprofiling some of those milestones, and you'll see that in the performance report. We have achieved some, but we've actually reprofiled another. So it is having an impact in that space, particularly in that area which is non-recurrent, and it, by its very nature, is short-term vacancies. In terms of eye care, the eye care programme is being reset. We've written a paper to Welsh Government looking at what are the options going forward, and we are awaiting confirmation from Welsh Government as to an agreed approach. I don't think 300,000 will be enough to do that. So, but it's really, what is it that they would want us to do in this financial year, and how do we fund what needs to be done? Having said that, they have already funded the work that Sam was alluding to earlier about the Microsoft rollout within primary care, for example. So there is already some funding that is in play that isn't shown as a DPIF project, and that was agreed. It's actually, you're right, Simon. Normally we do put the recurrent level in the slides, but our underlying deficit was around about 2.7 million, I think, when we started the year, when you added the savings onto it. So yes, we've got to come as part of that, building our future, and liquidate some of the benefits associated with simplifying our architecture, reducing our dependencies on licenses, and all the other factors that we've identified as part of the course. However, at the same time, we want to move to cloud. So it's really about balancing our ambitions with also liquidating some of the benefits associated with moving that. And Sam and I've got a session tomorrow actually to understand what that would look like going forward. So we have got some work to do to validate and confirm what we can achieve in order to mitigate some of those requirements as part of our 1.5 million and our deficit savings requirements going forward. Yeah, absolutely.
Yeah, if I make an observation, and Marion will recognise this, having been in a health board, I think it's really important that we remain very clearly cited on that figure, because it at some point can come round and bite you, because it is a real figure, and health boards have discovered this over many years, that continually year on year achieving savings on the basis of non-recurrent vacancy management at some point does come round and bite you, and it can bite you quite hard. So it's really important that we keep a clear focus on that.
Absolutely.
Sam, the other Sam Lloyd, and then Marion.
Thank you. I just wanted to comment further on Sam Hall's question about digital inflation. We've seen a number of market acquisitions of major software suppliers in recent months and years who are or who have been quite closely embedded in our infrastructure, and those market acquisitions have changed the way in which those suppliers are dealing with their customer base quite significantly, and that's what's caused some of the price rises that we've seen. We've found it quite difficult to manage through these situations and to negotiate, but through a lot of hard work across the organisation, we managed to get ourselves into reasonably strong negotiating positions, and we're able to mitigate those threats. But that's not to say there won't be further others that come down the road. So we are starting to engage with some market analysts to help us understand whether there are any other acquisitions of that sort of nature which are in the pipeline. Obviously, that's pretty sensitive information. It's going to be hard to come by, but we're trying to get as much on the front foot with that as we can be. I also think our best defense strategically is around making increased use of open source software so that we become less dependent on these major suppliers. So the movement to cloud can help with that, but equally we've got to look at how we adopt open source across our platforms, across our software products, so that we're much more masters of our own destiny from a cost perspective and less vulnerable to these kind of market fluctuations.
Thank you, Sam. Very helpful. And Marion.
Thank you, Chair. And thanks, Claire, for the presentation. My question is wider, perhaps. You referred earlier to the need to develop a sustainable funding model, and this is something that we've discussed several times over the past few months. Could you give us a flavour of how effectively this message is landing, and how likely we are of seeing a clear response to this before the end of the financial year?
And if I can add, that's really helpful you've asked that, and David asking the question, because my 2 points relate to both something David raised and you raised, Marion, is you describe it as joint effort, I think you said, or joint working. I think with absolute clarity that we might be jointly working to reach a solution, but the solution is not in our gift. So we just need to be careful that we people understand that we are not able to deliver a sustainable funding solution for ourselves. We can be part of the argument and the discussion and the process of how it's achieved, but we can't give ourselves that present, unfortunately.
Yeah, so given the current backdrop, obviously the Welsh Government have to make choices of where they invest the money. So there's two parts to that we're working on. The one is to define a narrative around the value that we create in digital and how that gives a high return, whether that's social value. We talked about time, didn't we, with the Welsh Nursing Care Records. It's really translating the benefit that we generate and the value that we create within DHCW. So we're doing a piece of work around the benefits, that is really bringing to life actually some of the value of the assets that we've already got and what difference they can make. At the same time, it's understanding what is a sustainable cost base for DHCW. And part of that work is translating what a new product-based operating model requirement is on the inference of cloud-based delivery and a simplified architecture to really substantiate what the ask is in the longer term, and bearing in mind that there'll be a transition cost associated with getting there. So alongside Welsh Government, there is also a question as to what is the right level of investment in digital. What is the benchmark against the other nations? So to complement that, we've done a piece of work to look at how other nations approach their investment to digital and where do we sit in relation to that. So we're hoping to conclude that towards the end of September and October so that we can publish that piece of work. But it's really about being able to demonstrate to Welsh Government the value that digital can create, and therefore to leverage the choice it should make alongside the ask and really crystallise what is the resource requirement we need in a new product-based delivery model, and marry those together. There is another dimension to this, which is actually in NHS England, they've identified the value of digital, and they've underpinned that with a significant investment. So it's also for us to consider what gains and values could a digital investment look like in NHS Wales, and how much of that could be subject and directed through some of the issues that some of the initiatives that we are currently doing. And there is a reality to it, as Simon suggested. It's not our choice. They've indicated that they don't want to continue with the approach of a DPIF related programme funding model. So it's also about working out what's the transition to the new funding model, because there are programmes that are multi-year programmes that have to continue at the end of the year. So there is quite a number of questions and answers and work that we need to do to underpin it. But we're working along with them to try and get our way through that in the most reasonable and sensible way, given the backdrop of the financial pressures within the system as a whole.
Indeed. Thank you, Claire. Okay, thank you for that, Claire, and addressing the points raised. And it's encouraging to see where we are at the end of the first quarter, but also recognising that there are still some significant challenges ahead of us. So we've been asked to receive that report. I'm sure we're happy to do so. Thank you. If we move then on to the next item on the agenda, which is 6.2, which is the corporate risk register. And if I could ask Chris Darling to introduce this item. Chris, over to you.
Thank you, Chair. Yeah, I'm going to pick up actually where Claire left off. So just reflecting on the current service and financial pressures that NHS Wales is under, there is huge opportunity to use digital data products and services to drive both efficiencies and improve patient outcomes. But in order to do this, we need to mitigate the risks that we face and turn some of the threats into opportunities. So with that context, just going to run through our current risk profile position from a corporate risk register perspective and get a couple of specific updates on some of our corporate risks. So there are currently 18 risks on the corporate risk register, 13 of which are detailed in the pack today. There are 5 private risks that are reviewed in private sessions of our committee meetings. Just to run through changes, there's been no risks removed from the risk register, no changes in risk score. There's one new risk, which is 0336 Audit Plus withdrawal of contracts, and I'll come back to that one. I just wanted to update the board on a couple of areas of focus since the last board meeting in terms of plan changes to the risk register. The first one very much links to what Claire was just talking about. So we're working with Claire's team just to review our risk around 0332 sustainable major programme funding and try and split that out into 2 risks probably. We're working that through at the moment, but one very much focused on the more here and now programme investment and some of the conditions attached to that. And the second one much more around the longer term sustainable funding model and how we get to that point working with Welsh Government and other partners to achieve a funding model that will allow us to move to a product-based approach. So just wanted board members to be aware of that work that we're doing, and that should be reflected then in future board meetings and obviously take it through the Audit and Assurance Committee. The second one, 0316, similarly, this is the technical debt accumulation risk that Sam Lloyd added to the risk register a few months ago. We've had some conversations more recently. I think there's a number of mitigating actions that have helped manage the risk, but I think further conversations have led to what we're planning to do, which is splitting out that risk into a number of component parts just to better oversee and manage the mitigation of that overarching risk. And I know Rowan's not here, but David and Marilyn and other Digital Governance and Safety Committee members are on. So we'll get into a bit of detail on that risk and how that's split out and how we manage that at the next DGNS committee meeting. There's then 3 risks I just wanted to pause on and ask colleagues to come in and update. So the first one was the Audit Plus one, which I'll ask Rydian to update on. And then there's 2033, the Welsh Intensive Care information system implementation. I'll ask Ivan to update on. And then 0334, the transition to DSPP and the in-house team that Ivan and Sam have been working on. I'll ask if Ivan can update on that one as well. So Ridian, can I ask you to just update on the Audit Plus risk, as that's the new one for us corporately?
Okay, yeah, Chris, I'll do that. Hopefully you can hear me better now. Just for background information, Audit Plus is a software application. It's used to extract information, data from GP systems, and it's used for various functions, which I'll highlight in a minute. The current supplier of that product, it's a unique product in the market, is withdrawing that, and therefore we're looking at how we can replace the functionality pardon me, that people are dependent on across the service. So it provides information that allows understanding of contract assurance frameworks, monitoring of specific enhanced services, particularly things like diabetes and injectables. It's an important role in improvement projects. It allows us to collect data for national clinical audits. It also allows identification and management of patients with chronic diseases. We have an element of supplying data anonymized to the sale, and also there's prescribing safety modules. There's population health management, things like monitoring smoking, BMI of the population, and data for public health and health improvement initiatives across Wales. So we put a team together to work out who are the key dependents are, who our stakeholders are, what the scope of the data provision that we need to provide. It's worth noting that the current scope of what's delivered is far in excess of what was the original procurement some years ago. We're doing impact assessments on the various key stakeholders, and we're exploring different options. Some of those options are commercial. PIN notice and supplier briefings have been issued. Some of the functionality we may be able to cover in-house. Some of it may be a blended approach. We have a strong team that are working on this all the time. Very good support from commercial services. We've got a primary care information service team. We're involved with information governance. We've got a communications strategy to keep those stakeholders informed, and we're utilising some of the skills of the National Data Resource. So it's work in progress, and I hope that at the next meeting we'll have more positive news about how we're replacing this functionality for which many of our partners within the NHS are reliant on.
Thanks, Ridian. Just pause to see if there are questions on Audit Plus specifically.
Go on, David.
Yeah, thanks for allowing the question, Chris. Ridian, why are Audit Plus not wanting to continue? Is it because it's a legacy product and they will spend too much to renew it? Why is there an issue of them not continuing?
There are some commercial sensitivities about that, David, but it's no longer a viable product for the supplier.
Okay, all right. Thanks.
Thanks, Ridian. Ivan, do you want to update on the two aforementioned risks?
Thank you, Chris. I'll take them one at a time. Firstly, risk 333, which is WICIS, or the intensive care system. I don't have a lot to add apart from what's in the risk note that's included in the paper, and that says that Welsh Government is commissioning an independent report into some of the issues that have arisen in terms of the system. That work has begun, so the Welsh Government have commissioned and set forward with moving that work. That's going to be moving ahead over the coming weeks, and we expect it to report towards the second half of August, I think, and that then will provide an opportunity for us to be able to move forward. Clearly, there is close collaboration with the supplier and with the health boards and the Welsh Government on this, but the work has begun. I think that's the important thing to emphasise, and it's proceeding. I'll stop there in case anybody has any questions on WICIS. No, Okay, if that's the case, I'll move on to the second risk. Perhaps Sam might want to come in to add something here. The reporter, I can't even remember what the number is. What risk number is it? But 334, there you are. So we've identified a team of our own staff. They are being placed in to work as part of the supplier team. So an app is being developed on our behalf by a supplier called Kainos. They have done very good work, but of course they're a commercial company and there are higher costs associated if we use commercial resources to develop software compared to using our own engineers. So we have put a team of people in to work alongside Kainos. They will be there for about 3 months, 2 to 3 months, in order for them to be able to familiarize themselves fully with the architecture and the system and with the design and the management of the system as well. And they will then come back, and the intention is that that will provide us with options in relation to being able to collaborate with Kainos firstly, so that we are able to deliver some of the work that we currently purchase from Kainos, and looking further into the future then that we may be able to take a more substantial part of the development work as well as the maintenance work of the live service. I'm very pleased that we've been able to identify people within our own teams who have the skills and the ability and potential, but also the enthusiasm. And there was a huge amount of enthusiasm to work on this app. And I will just add as well, in terms of where we're at the moment, we are at about 240,000 users on the app. So usage is continuing to increase, and this is a really important service for us as an organisation. And I'm looking forward very much to our own teams being able to do the developmental and maintenance work on this national app. Any questions?
No, it looks like people are comfortable. Chris,
sorry.
anything you want to come back on now? Or have you? Oh, Sam Lloyd.
Apologies, I couldn't find the hand raised button quickly enough. Yes, I just wanted to add to what Ivan has said, that we're well underway with the transition of our internal staff into Kainos to work alongside them on the development of the app. We've identified 12 roles, of which 9 are now filled, and a good proportion of those are with internal staff. So this is a really good opportunity for our own teams to spend time embedded with a national provider of software and really bring some of those skills back into DHCW. It's an important part of our transition to a product operating model as well, because we're transitioning this delivery from program to product as seamlessly as we can. So it's important from that perspective as well. We put measures in place to make sure that the staff who we are embedding are actually able to take on those skills, and so we've got not exactly KPIs, but mechanisms to ensure that the delivery that we're getting is going to continue at the same standard. So we're doing all that we can to ensure that this is transitioned as smoothly as we can.
Thank you, Sam. Just one observation, Chris, around the sort of the risks on sustainable funding as to whether we ought to ask Marion, if Marion is comfortable, for the audit committee to take a specific and close attention to it, and given how critical it is and also the time. I mean, we're at the end of we're in the beginning of the second quarter already, and time will just fly. Not a great deal tends to happen through August, so you find yourself in October before you know it. So whether we could ask Marion to take it in to take oversight of that particular risk and where it's heading into the audit committee. Go on, Chris. Marion, are you happy? Yeah, it also has the advantage of taking it close to our Audit Wales colleagues, and has significant implications for. Okay, Chris, anything you're comfortable with that?
Yeah, Diolch, Marion. Yeah, I think it's a really good time as well, as we split the risk out and really get into articulating it. We can make sure we've got that mechanism through to the board to track it in terms of. So I'll work with Claire and Marion happily to get that in place, Simon.
Okay, unless you've got anything else you want to add, Chris, we are being asked to receive the corporate risk register report. I'm sure we're all happy to do that. Thank you very much, and move on to 6.3, which is the Senior Information Risk Owner Annual Report. And the Senior Information Risk Owner is Sam Lloyd. So over to you, Sam.
Thank you, Chair. I am indeed the CIRO for DHCW, so I'm pleased to present this annual report on our information risk management framework that we have in place as an organisation. This report provides an overview of the information management approach in DHCW, a summary of the key developments relating to improving information risk management in the last financial year, information on some of the audits which provide assurance relating to that framework, and information and data around incidents and so on. The report also concludes with a forward plan of activities which aim to further improve our framework. So to begin with, we have a comprehensive governance structure to support effective information risk management, which begins with the delegation of responsibility from Helen as Chief Executive through to me as Senior Information Risk Owner and Ridian as the Caldecott Guardian, then through our community of information asset owners who are responsible for the security and information governance of their own systems, through our data protection officer, who's responsible for carrying out particular tasks in relation to personal data as defined in GDPR. We have the information governance team who support the work of the DPO, the cybersecurity team, of course, who are responsible for technical assurance and control measures around information security, and then our corporate Power BI team, who are responsible for ensuring compliance with Power BI assurance framework, which is very important as Power BI is used as one of the primary mechanisms of making data available to the wider system. So it's really important that that is done safely. We also have two committees of the board which have oversight and assurance of information risk management. So one is the Digital Governance and Safety Committee, and the other is the Audit and Assurance Committee. We, of course, have a range of processes and controls which are in place. I won't list them all, but they include the information governance strategy, they include the information asset policy, a range of information sharing agreements, and so on. And then we also use digital tools to help us with consistency of process and assurance. We have defined specific risk appetite statements with regard to information risk management. They are all in the either averse or cautious category, which demonstrates the importance of storing and sharing information safely. The distinction largely is around storing and maintaining of data and compliance. We have an adverse position around, but then with regards to sharing and service delivery, we move to cautious because we recognize that some degree of risk needs to be taken in order to share data at all. Then to move on to some of our improvement activities that we've undertaken in the previous year, I'll just pick out some highlights from the report. So we heard from Mark Edwards in the private session earlier about the implementation of the 3-year cybersecurity plan and the progress that's being made there. There's a lot of work that's being done across the infrastructure teams around retirement of legacy infrastructure. As we've discussed before, this is one of the major risks that all organizations face. So migrating away from legacy services or legacy software such as Server 2012, SQL 2014, etc., is a key part of our information risk management and cybersecurity posture. There's good progress being made across that, and work such as the cloud migration program, which we alluded to earlier, will continue to strengthen that. We successfully renewed the accreditation against NHS Digital's secure email standard, which means that all users of our NHS Wales email service can continue to exchange sensitive information, including PII, patient identifiable information, with users of NHS Mail. So that's connecting millions of people together to share patient and other sensitive information safely. We conducted a cybersecurity briefing for board members across all NHS Wales organisation. That was a very well attended session that we had really good feedback on, and something that we're looking to continue with. We had guest speakers from the National Cybersecurity Centre and from some of the organisations that we've discussed previously who suffered ransomware attacks, who are thankfully very keen to share the benefit of their experience in learning from those incidents with us as a system. We have delivered an information governance strategy, which includes 4 aims around ensuring that we meet our statutory obligations, providing organisations and professionals across Wales with IG advice, guidance and services. So that's our national IG remit. Continuing with the development and implementation of policies that build trust with patients and the public, and then embedding the duty of quality within our IG function. Within the last reporting period, the last financial year, we've had a number of audits which have looked at our information risk management and cybersecurity posture. Again, just to highlight a couple, so the ISO 27001 audit, so we were successfully recertified against that standard, which is a very comprehensive and thorough process and does demonstrate a good cybersecurity posture and information governance posture on our behalf. The Welsh IG toolkit, so DHCW has got two responsibilities in relation to this. So we actually maintain and develop the toolkit on behalf of NHS Wales, but we're also obliged to complete and submit that toolkit ourselves every year. So we did that, of course, last year and have achieved a high level of compliance against the conditions that are set out in the toolkit. The report has a summary of the information, freedom of information and subject access requests. I won't go through those, but that we can see that we receive those at a steady rate, and we are generally and frequently replying to those within the statutory time limits. We had a very small number of information governance incidents, and none of those were reportable to the Information Commissioner's Office. We've got 3 risks on the corporate risk register which pertain to information governance and information risk management. I won't read through them, but they're available in the report. And then finally, just to summarise some of the planned activity for the coming year. We will continue with the delivery of the 3-year cybersecurity plan, which includes implementing the new national cyber event monitoring system, which we heard about earlier, which is being deployed across all health boards in NHS Wales. We will deliver updated cybersecurity board training for this board, for the members of the DHCW SHA board. We're reviewing all of the externally published Power BI dashboards, which, as I mentioned, are one of the key measures by which we provide data out to the wider system. We're going to continue to embed and promote the IG framework. We're finalising the Welsh Accord on the Sharing of Personal Information Code of Conduct, so the WASPI Code of Conduct, following public and stakeholder consultation, and continuing to extend and expand the IG toolkit to those organisations that want to access patient data. So there's quite a big piece of work that we're looking to do over the next year or so to really improve the means by which the IG toolkit is accessed, and also to look at combining potentially the cyber assurance and information governance assurance mechanisms that we have in place into something that's a bit more streamlined. There's an opportunity there with the recent alignment of the cyber resilience unit as well. So I will pause there. Happy to take any questions. Thank you.
Thank you, Sam. Any questions or comments on Sam's report? No, but I don't think we should take the absence of questions or comments as an indication of how important this issue is, Sam. It is so important. It is so critical to so many things. Okay, and we've been asked to receive that report, and people are happy to receive it. I'm sure you are. Thank you, Sam. But don't go away. Item 6.4, we're going to get an update on the data center 2 move, and Sam Lloyd is going to take us through this. Over to you, Sam.
Yeah, thank you, Simon. We have recently completed, or we have been undertaking a program to relocate our data center capacity effectively. So we had a contract that was coming up for renewal in June of this year. So we've undertaken quite a long period of about 2 years worth of work to transition all of the infrastructure and services which are held in that data center to a new hall in the same facility. The original target date to complete that was March 2024, but we did have some issues with service readiness in the new hall, so the suppliers were a bit late in handing it over to us. We encountered some issues with the configuration of our new network, and we therefore agreed to move the date back to June 2024. So I'm just going to give an update on where we are with that. So the current status of the program is that the work has been successfully delivered. Effectively, we're now in the close down phases. That included transitioning a new network, moving all of the circuits from one facility to the other, transitioning all of the active equipment. So we had to physically move quite a large amount of server and storage environment from one place to another, ceasing all of the legacy circuits and the racks, handing those all back to BT, who are the supplier of that facility. And therefore, through doing that, we've achieved all of the primary objectives of that migration, which were moving to a more energy efficient facility. So we've reduced our carbon footprint by about 21%. We've reduced our power usage in that facility as well, which also gives us a better position with regard to financial risk of any future increases in power charges, which obviously we were seeing quite regularly a couple of years ago. We've saved about £300,000 on costs in rack, so the number of racks that we're consuming and power consumption. We've installed a new network in that environment as well, which is helping to ready us for our cloud migration program. We had legacy networking designs and equipment in that area, which we've now modernized to something which is much more software defined, which is going to make it much easier for us to move to cloud in hopefully the fairly near future. And quite importantly as well, we avoided a contract extension with the existing supplier, which was something we didn't want to do because we were out of contract and we would have had to have gone through commercial processes to get to that point. So we will produce a full project closure report at the end of Q2. So this document is not that. There are still further lessons learned that we're processing at the moment, but we're not expecting to come back to this board with the full closure report. But that will be produced. There is a little bit of remaining work around rack disposal and some cabling and stuff to be stripped out, but essentially we are at the point of completion for that program. From a budget perspective, we set our budget based on a previous data center move that was undertaken in 2021. So we rolled those costs forward. On that basis, we were actually able to come in quite significantly under budget. And the main reason for that is that we did a lot more of the work ourselves than we had initially forecast. So rather than contracting third-party suppliers, we were able to do a lot of that work with our own resources, which has reduced the costs significantly. As I mentioned, we will undertake a full lessons learned in due course, but we have taken on board some initial lessons at this point. Probably most importantly is that we should have undertaken a full cable audit, which because the network environment in that facility had developed and evolved over a number of years, which then causes complexity, which then makes changes much more high risk. So we should have undertaken a full audit of that cabling and network environment in order to make sure that changes that were undertaken were planned and executed without issue. We should have included some additional contingency because the supplier, as I mentioned earlier, did take a long time to get the new hall ready. That was outside of our control and did affect the overall timelines for the delivery of the program. We did back in November, members will probably recall from the major incident report, we did have a series of failed networking changes that occurred as part of the move. So on the back of that, we engaged a third party to help plan, ensure and undertake those networking changes with us. And with hindsight, we probably should have done that earlier. So that's a key lesson for us to take. But overall, we have undertaken the work successfully. We've concluded the program, we've delivered it under budget, we've reduced our carbon footprint, we've set ourselves up in a position to be better ready for cloud migration programs. So all in all, it was a success, I think. I'd like to take this opportunity to say a very big thank you to our teams who worked, as Helen alluded to earlier, over a long period of time, many evenings and weekends in order to get that work done. It really was a huge display of dedication on behalf of teams across DHCW. So I would just like to thank them publicly for that work.
And I'm sure the board would want to echo those thanks because these things are not easy. And with the exception of a few, well, for want of a better word, glitches that you've identified, it seems to have gone remarkably well. And I'm sure Claire's remarkably pleased that it went remarkably under budget as well. Helen, you want to come in?
Yeah, I just, again, echo the thanks to the team, and the complexity and risk involved in the undertaking. It's huge. The significance of this is huge for us as an organisation, and what it facilitates for us now in terms of opportunity already. Kind of, significant kind of progress against our decarb plans just by very nature of the, if you like, to simplify it beyond what we should be, perhaps the housekeeping exercise that we've been able to do in terms of stripping out legacy and modernising both the network and the infrastructure that our services and systems kind of use is just been a tremendous opportunity, and just it's made us all smile in terms of it coming in under budget as well, given that this was funded through internal savings, which was quite a challenging year for us last year, isn't it, in terms of all of the savings we've managed to make. So I just want to congratulate the team on that, really. Thank you.
Okay, so thank you, Sam, and the whole team being involved in achieving a very excellent outcome. I can't see any questions or comments. Okay, thank you. Been asked to receive that report for assurance, which I'm sure we're all happy to do when we all feel assured. If I move then on to the next item, 6.5, which is report on the 2023 NHS Wales staff survey, and invite Sarah Jane to introduce the item. SJ, over to you.
Thank you, Chair. Yes, and delighted to present the report and to just go through some of the key findings, really. So this was for the 2023 time period. There were 10 key themes. They covered an array of things: morale, patient safety, staff engagement, compassionate, inclusive environment, recognising everyone's contribution, ability to speak up, stronger together, championing flexible working and nurturing healthy working environments, and continuously learning and improving. So quite an array of things really for us to ask questions on. This was part of the NHS Wales staff survey. So we've been doing our own local ones over a number of years, but this was one that was taken across the whole of the NHS Wales. On some of the really positive side of things, we were the second highest in terms of the response rates, so over 60%, which is great. We're really pleased with that. And we were first in terms of our engagement scores, over 80%. So they are formulated through a range of questions. So again, that was a really great indicator for us that we feel like we, as a values-led organisation, a compassionate leadership organisation, as we discussed earlier, that's great actually that we've got that really high engagement score. So I think in terms of some of the positives, really, I think 82% of people would recommend DHCW is a good place to work. Really, 92% felt that they were trusted within their jobs. They were satisfied with the working environment. And very, very many people, 87%, said they were happy to go the extra mile. And I think some of that links to, what Sam's just been saying, really. We know that we've had a number of key areas that have had peak periods of tremendous effort invested. And I think that demonstrates that incredibly. I think it would be worth mentioning some of the areas of focus and what we're going to do about those. So there was a few areas of focus. I think the frustrated and burnt out 65% people felt that there was quite a lot of pressure. 58% of people felt quite a lot of pressure of work and workload. And I think the other one, which wasn't a huge high indicator, but one that I just wanted to talk through really, was 28% of people didn't know whether it was good or not good in terms of our diversity and inclusion, promotion and progression opportunities, and if we are doing everything we possibly can do. So it's not a negative as such, but I feel although we're going to take through all of the findings at directorate level, at the senior leadership teams, look at the action plans that are already in place from last year's local DHCW staff survey, and co-create that and do some wellness and some stress toolkitting as part of that. And that will be done with my people and OD team, and I'll get involved, and Shikala, my deputy, will get involved as well. But I think in terms of the diversity and equality one, I'm really keen, and I spoke to the team a couple of days ago, about we need to start showcasing what we're doing, how we're doing, and making it a bit more systematic so we can do something perhaps at management board on a regular basis, just to make sure that we are tracking and showcasing that, because I think there's a lot of interest out there, and we also need to encourage and promote people to put their names forward and to be part of, you know, promotion exercises. So it's just something to say it wasn't a massively high negative, but it's something that I feel really strongly about that we need to do something about. So really happy to take any questions or observations, and just to provide assurance to the board that this will all be worked through and co-created at directorate level into action plans and tracked and monitored at the senior leadership team meetings, and then reported back on in 6 months more formally through management board and potentially the SHA board as well. So thank you very much.
Thanks, Sarah Jane. I've got a few people wants to come in. Marion and then Helen. Oh, Marion, you came off mute, but you're still mute. Okay.
Can I congratulate Sarah Jane and the team and the whole organisation, actually? I think we have a fantastically positive score here, don't we? And so many people who have been involved in this survey, which is really positive in itself. And there are a number of scores that are exceptionally satisfactory that we can take great pride in. Can I just ask a question about the perhaps more negative score on workload? It's good to hear about the actions you intend to take to address workload pressures that some people feel. Can you elaborate perhaps a little bit as to where the heaviest workload pressures are, in which departments they are seen? And was that did that come as any surprise to you, bearing in mind the challenges the organisation is currently facing?
Yeah, happy to answer that. Thank you, Marion, for the question. Yes, good question. We have done the directorate slices now, so all the directorate information is available, and it will be worked through with the senior leadership teams and the directors at directorate level. And you're absolutely right. The operations directorate actually are probably the one, and it was no surprises that there were quite a lot of hotspots there, to be honest. And I think the other thing that's been going on in the last year or so, we've been doing lots of organisational change. We've been doing a lot of parallel running. We've been doing some stop-starts of things, as well as big pieces of work like the data centre move and so forth. So I think that was probably the directorate that had the most negative indicators. But I think, as you say, there were probably no surprises in that space, really.
Okay, Helen.
Yeah, thank you, Chair, and thanks, Sarah Jane. And you know, good to see this at the board. And I think, as you say, Marion, some really positive indicators coming through, and hopefully for this year's survey, we will improve our coverage as well and get more of our team to answer and participate in the survey, because the intention is that we build up, as England have done, NHS England have done, kind of a really depth of the data that we need to plot it and trend that going forward across NHS Wales, which I know is Health Education Improvement Wales's intention. I suppose one of the things, just to pick up on the point that Sarah Jane made around the inclusion, really, and how kind of the awareness of the inclusion, I think the board will see some more work on this, because we participated, as did every other organisation in NHS Wales, of the race equality survey. And we've seen some of the results of that locally, and we had a presentation on it at NHS Wales Leadership Board this week. So we've got a deep dive into our results. I believe it's September, Sarah Jane. So I think that's something that we can bring back to the board to consider, really, in terms of what are some of the kind of key actions we need to take in that space, because there will be inevitably key actions for us to move forward, both us and every organisation in NHS Wales, to ensure that we are genuinely offering equal opportunities to all teams, all members of our team. Thank you.
Thank you, Helen. Got Chris, Marilyn and Andrew. Chris.
Thanks, Chair. I've got a couple of points. The first one is, it's great to see the engagement score and the uptake level, fantastic from an organisational perspective. I had a similar point to Marion in terms of the burnout, and actually the staff survey happening now before we really get into delivering the building our future and the transformation program. I think it's a good benchmark at this point to see in a year's time how that change does or doesn't impact on some of the indicators through the staff survey. So I think that's useful. And then on that theme, really keen to see how our scores benchmark with other NHS bodies. We are different to other NHS bodies. However, the questions are the same, and some of them I think are directly comparable. So I think that would be really helpful to understand where we are in terms of knowing if they are positive, negative, etc. So that would be helpful. And the last one is just around the ability to speak up. And I know this is more than just the formal raising concerns process, but I think a relatively positive score, and we've done some proactive work to promote this. We want to, we are a learning organisation, and we want to encourage staff to feel empowered to challenge and raise concerns when they need to. So again, as board champion, along with Marion, for raising concerns, really keen to keep an eye on this indicator and how it might change over the years.
Yeah, if I can just, because Chris has picked up on the only point I was going to ask really, SJ, is that when you go into the appendix, it gives more detail on our data, but is there anywhere you can go which shows the entirety of the results in terms of those comparative?
Yeah,
there's things like morale is important, would be an interesting one for me.
Absolutely. I think it's a bit of a mixed bag, if I'm perfectly honest. It's taken a while to support getting the data packs and then interrogating that information, and a big thank you to Bernadette in my team and Martin Williams in the Power BI team. It's been quite a churn. We can do some of that. However, I think some of the return rates for some of the others were sort of 12-15%. So we just need to look at that in the round, really. Ours was over 60%. So we do need to make sure that we are comparing apples with apples and not apples with pears. So I guess, we'll try to do that with somebody like DHCW, which had really good response rates as well, and they're a very similar organisation, and perhaps some of the others. But we need to pull that all together. Not everyone has finished all of their diagnostic yet, so we haven't got a composite of everybody's. But once that does come together, we will definitely be able to provide that. But it would just be with a little health warning to say not all the response rates were very high, so we just need to be careful about making sort of key assumptions.
Okay, and Chris's other points? What were your other points, Chris?
Well, I think there are probably more comments in terms of some of the change taking place over the next 12 months and reviewing whether any of the metrics have changed. The other one, Simon, for me is all the comparator with other NHS bodies, but also the intel that their staff survey results show us. We are working with them to deliver products and services for them. So understanding some of the workload pressures, etc. From a provider perspective, I think gives us insights in shaping our delivery and partnership working.
Yeah. Thank you, Chris. Marilyn and then Andrew.
Thank you, Chair, and thank you, Sarah Jane, for that presentation. I'm heartened to see that we're looking at the things that we need to improve on, because the satisfaction is great. It tells us what we're happy about, but those are the things that sometimes we can glean. And as Helen, you've said, it'll be really good for us to have a look at that benchmarking across other organisations for the race quality information and that we need to provide, as well as on other equality strands. So I think it'll be really good for us to have almost like a deep dive into that in the future and see what that's actually telling us. And also just a reminder that sometimes people only engage when they want to say something. So there'll be loads of satisfied people who don't actually respond. So I think we just got to really, bear that in mind as well. So yeah, thank you for that.
Thanks, Marilyn. And Andrew.
I think the only thing for me really was, I'm not going to repeat everything that everybody else says, because I'm pretty much saying the same things. But it's just to assure everybody that we'll work together where we can with people on OD, because the board aren't very often cited on all the conversations we have about things in the organisation. So it's just probably to let everybody know that we do talk in depth about a lot of the things that come out of this. The only other point I was going to make was that there might be some things that on an all Wales basis that there may be NHS-wide reasons that why people are not feeling happy that are not necessarily our organisation. So it's just to note that really that sometimes we feel things as a service and it's not they aren't organisational problems. And that was about it really.
Thank you, Andrew.
So thank you.
Yeah, thank you, Andrew. Thank you very much. SJ, thank you for that report. I mean, obviously very encouraging. Obviously, got to keep an eye on things, and equally, I think Helen's point around data is only useful when it shows you trends in these things, these sorts of things, really. So thank you very much for that, and we've been asked to note that report, and I'm sure people are happy to do so. If we move on then to item 6.6, the Integrated Organisational Performance Report, and Claire, you are introducing this item.
Yes, I am. Thank you, Chair. The report and the attachment alongside it shows that the scorecard at the end of the quarter had 10 indicators that were green, predominantly in finance, workforce, clinical, and as parts of governance. There were 5 amber, and there were no red indicators of any note. But what I am going to do is just give you a few highlights from the report that's in the pack. In terms of delivery, during the quarter, we achieved 70 milestones out of our 326 milestones that are planned for this financial year. Some of those we've discussed some of this already, so I will skim over some of it. But some of those deliveries and some of the slippage that we saw in some of the milestone related to the NDR, and that really reflects the funding letter and the delay in the funding letter, understanding our allocation, and then translating that allocation into a revised set of milestones. It's also important to note that during the month we did have a number of incidents, of which one was red, and that resulted in a major incident that related to one of our data centres. And I think at this point I wouldn't mind bringing in Sam just to give us a bit of an update and outline the circumstances surrounding that particular MI, if Sam's there.
Yeah, thank you, Claire. So this was a data center incident which was actually triggered by a fire detection system which incorrectly identified a fire in the facility, which then switched the cooling from the primary cooling to a backup cooling system, because it has to seal off the room to allow gas to be discharged. So the main fire suppression mechanism is via gas discharge. So the staff in the facility realized that this was not an actual fire, and they prevented the gas from being discharged and then failed the air conditioning back to the primary. However, that failback didn't work correctly, which then caused the temperature in the room to increase, and then some of the equipment in the facility to power itself off in order to protect itself from basically burning out due to overheating. So the supplier notified us quickly. They identified the root cause and they reset the air conditioning and got it back up working again. But by that point, we did have some server outages or system outages. So the actions that we took were to invoke our gold, silver, bronze out of hours major incident management system. We invoked our communications protocols, and we did have all services back online by later that evening. A large number of our systems were running from our other data center. So we have 2 data centers, and a number of systems are resilient or are configured in a resilient manner across the 2 of them. So some services were unaffected, others failed over as expected. But some of our services did not fail over as expected. So there were 32 services affected in total. The restoration time for those services in total was 5 hours and 55 minutes. 3 of those breached the SLAs for recovery times. So that did make a bit of a dent in our availability numbers. That took the availability for the month slightly below our target of 99.9%. So we dipped to 99.866. So very slightly under, but under nonetheless. So we're in the process now of doing the full major incident report and lessons learned report. We've already had sessions with the suppliers to make sure, or the supplier of that facility, to make sure that they are putting better testing mechanisms in place to ensure that the failover between air conditioning systems is tested regularly, because it was a switch that tripped out during the failback, which caused the outage. So there's some questions for them to answer around their maintenance regime. But we're picking that up with the supplier. The affected fuses have all been replaced and upgraded. The fire alarm system has been tested, and there's a range of other activities such as moving fuse boards and reprogramming control systems and so on, which is now underway in order to prevent a recurrence. Thank you.
Thank you, Sam. So operationally, obviously that hit our amber during the quarter. Other notable deliverables within that mission related to the dental access portal that we've already discussed, and we have seen an uptake in the NHS app, and a redesigned feedback mechanism is in place, which has had a positive impact on how users access the system. A number of milestones fell behind in cancer relating to resource, and again that's been addressed. And then in terms of the decommissioning work on the track and trace that I mentioned, that was activated, and the data will now reside in the NDR and safely to get decommissioned as expected. Within Mission 4, there's been activities in and around R&I, where an application for a grant to develop an AI model has been worked on during the quarter. And then finally, in Mission 5, to be a trusted strategic partner, we note 100 milestones were planned. We achieved 70. We then undertook, our headcount has gone up to over 1,273, and our turnover is at the lowest level since 2022. The quality management process has improved by 4% to 89, but is still behind the 90 target. We visited Betsy Cadwallader, as you alluded to in your reports earlier. And again, in terms of stakeholder, we've now received 292 responses to the stakeholder survey that we're undertaking. And again, that will be analysed and reported later later in the year to the board. So significant activity during the quarter, and again, happy to take any questions, Simon.
Helen.
Yeah, I wonder whether perhaps Ivan, perhaps we want to unpack a bit of the milestone performance that we've seen just in the first quarter, really, and I guess really just try to understand the materiality of the milestones that have been missed and that we are having to reprofile, and whether that our confidence, I suppose, that the impact that's going to have on the plan overall for this year.
Yes, of course. Thanks, Helen. So to remind everybody, we have a system whereby the 6-year strategy, we have the IMTP is over 3 years with delivery pathways in that. And then we've got an annual plan, which is full of milestones, around 540, I think, milestones. And then behind those, we have constraints, around 2,000 of those, and they're all interwoven, and there's a process throughout the winter months of working with teams to estimate how much work there is, and then to plan a program throughout the year. So we're looking at our performance against those milestones. We do that on a monthly basis through the management board. We now report to Welsh Government as well on a monthly basis on our milestones against all the DPIF programmes, and before too long we'll be doing that through IQPD, the Integrated Quality Performance and Delivery meetings that are also moving to be on a monthly basis, as they are for all health boards. So there's an awful lot of eyes on these, and in the most recent meeting, which was the meeting, I think it was around the 10th of July, I think, we were looking at the performance to the end of June, a fortnight before, and we could see as a management board that there was some slippage. Some slippage had been in the milestones that had been planned for the end of June, and very quickly there were around 30 of them that had slipped. And when we talk about slippage, they are reprogrammed within the year. So they move, they're delayed by a month, 2 or 3, and so forth. For various reasons as to why they slipped, some of them slipped because of some kind of difficulty, perhaps with one of our suppliers, for example. So that's beyond our control, apart from through contract. Others slipped because of the relationship we have with other NHS bodies that we work in close partnership with. They have planning and delivery and implementation plans and so forth. So if there's any slippage in that regard, then we negotiate and work with them to try and get the timetable back on track. And then there are some also then that slipped because of the move in finance, as Claire mentioned. And it became known to us at the end of March, but too late for us to be able to reflect that in our plan for the year. So we are working through that impact. Also, though, there were a number of milestones that slipped because of pressures within our own organisation. And that is a concern to us. So we can see it happening immediately. You know, it's almost like a real time within a fortnight of the end of the month. We can see exactly what's going on. And that is a first step. Of course, a very important first step to be able to understand what's going on within the organisation. We are understanding what's going on within the organisation. There are elements of it that are disappointing, I would say, in the knowledge of how much emphasis we've put on tight planning for this year and over the past 2 years through the planning process that we have. So for those, particularly for those within our own organisation, i.e. the relationship between teams across the organisation, we will be working very, very hard over the coming 2 months to be able to tighten and bring that performance back by the time we get to the halfway point or the Q2 point. Helen was asking about 2 things. What is the materiality? So how significant is this? It's quite difficult to say at the current time without going into every one of those milestones. And there's an owner for each of those milestones. And we are familiar with things moving around during the course of the year. So I don't have a comprehensive assessment for you as to what impact this will have on the services that we deliver. Usually they are to do with new things or providing or delivering change in a way. So there's no impact on live services, for example. It's more to do with the speed at which we can deliver new things and new features, but it's still disappointing. And the second question was, what level is our confidence of bringing things back? We track those milestones. We currently don't track any kind of measurement of confidence in delivering every milestone. So some kind of red, amber, green, or a percentage confidence level. We don't do that. We expect the owner of each of the milestones, and there is an owner for all 550 of them, we expect them to realign and reset, and they do that in good time. So I'll just conclude with perhaps the biggest disappointment for me was when we met in June and asked, are we on track for these milestones, all of them by the end of the month? The answer was, well, yes, we are, because nobody had informed that they thought they were going to slip. But 2-3 weeks later, it turns out that around 30 of those milestones really had slipped. So I have a high level of confidence that we know exactly what's going on. I have a very high level of confidence that we know who's responsible for each of those milestones. And I have a very high level of confidence that we understand the relationship between those milestones and the constraints that we face in our organisation. So we have all that information to work on. I'm always a glass half full kind of person. So I'm quite confident. I have a reasonable level of confidence, I would say, that we are going to be able to pull back some of those things by the halfway point of the year. That's our priority. So at the moment, the programme shows that we have a high level of confidence of delivery within the whole year. Nothing has slipped beyond next March, but I don't want to rely on that. And my advice for the board is not to do that, but to focus on bringing things back before the halfway point, so before the end of September, so that we can see a far healthier report when we come to the first week of October. So hopefully that will provide a quite full picture for people as to what's happening and how we're responding to it.
Diolch, Ivan. I think Simon, no reflection on your answer, has lost his microphone and audio, so we'll just go to any further questions. Marion.
Thank you, Chair, and thanks, Ivan, for that very detailed clarification as to Mission 5. My question relates to the milestones. Clearly, as you've mentioned, there are a number of them that are beyond our control and reliant on the performance of health boards and so forth. But in terms of those milestones that are within our control,
Liam.
It appears that the fundamental question is, are we setting attainable targets? Are they realistic? And are there lessons perhaps in that regard, maybe, in terms of how we determine our targets around hitting the milestones? A very good question, Marianne. I think historically, we have tended as an organisation overall and as teams and as individuals to be optimistic as to what we promise and plan. And that is because we want to please very many of our stakeholders, and because we want to do so in as constructive and positive a way as possible. Over the winter period, as the teams plan, we and the board of executive directors will be pushing back on the teams to not over-promise and to be realistic, as you've mentioned, as to what we are able to achieve within the course of the year. And that's why we've introduced the blue and the yellow in the IMTP, for example. I think that there remains perhaps a little bit of optimism in the plan, and we can see that. We can see evidence of that at the end of the first quarter, but this is the best way of learning, I would say. And so I don't want to use that as any kind of excuse. Our task is to deliver according to what we've planned to deliver. So that's a key part of planning, isn't it? And I want the organisation to be an organisation that can plan well and can deliver well against that plan. So that's what the message will be, and that is the message already. And over this quarter, that will remain the message. Thank you, Ivan. We are a relatively young organisation, aren't we? And it's important for us to learn on an annual basis of our existence from year to year, but thanks.
Okay, can you hear me? Thank you, Ruth. On average, my headset goes down every 2 meetings. I think I'm on my 3rd or 4th set now. Claire, anything you wanted to come back on?
No, I think Ivan has given a very thorough response in terms of the milestones and the slippage and how we're managing those and bringing those back on track. And I think we've covered most of the points actually throughout the meeting, which was really helpful.
Thank you. Thank you all. We've been asked to receive that report, and I'm sure, again, we're happy to do so. Okay, we've just got 2 committee meeting reports to receive. The first is the Audit and Assurance Committee highlight report, and ask Marion if there's anything you'd particularly like to draw to our attention, Marion.
Thank you, Chair. Well, it's a pleasure to present this report to you from the last meeting of the Audit and Assurance Committee. And it was lovely to see satisfactory progress made on several levels. There were 3 reviews undertaken by the internal auditors, and we were given a reasonable assurance on those 3, including decarbonisation. It was good to see excellent progress in terms of delivering the strategic action plan on decarbonisation, but there was one recommendation that stated how important it is that we as an organisation develop a funding strategy for the medium to long term for funding the work of decarbonisation. And I know that the organisation is looking at this in detail, and in a way it echoes the themes that we've heard throughout this meeting today in terms of the budgetary pressures we're facing. This was the meeting, of course, where we had to approve the annual accounts, along with the annual report, which comes before our annual meeting later on today. And I would like to outline how lovely it was to hear about the excellent relationship that has now evolved between our finance team and Audit Wales. Clearly, the relationship has matured further over this past year, and I think everything we heard at the committee meeting really outlined that we can have a very strong level of confidence in the work that our finance team undertakes, led by our finance director's excellent leadership. We also updated on the risks that have been set aside to the committee, and as champions of the Welsh language, in terms of the independent members, it was also a pleasure to receive the annual report that will be submitted in due course to the Welsh Language Commissioner. There was also an annual report on more than just words. And the one thing I would like to note is that I think we are aware that there's a need for us to strengthen that element relating to the Welsh language within our recruitment strategy. And that is something that we will revisit, I'm sure, over the coming year. We had, before concluding, we had an update on the work that's currently ongoing on the structured review. The work is proceeding satisfactorily, and it appears that we will receive the report, the full report on that at our next meeting of the Audit and Assurance Committee in October. That's all I wanted to note in passing, but I'm very happy to answer any questions.
Thank you, Diolch, Marion. Helen.
Yeah, diolch, Marianne. Yeah, just a question really, or well, an observation more than a question, on the decarb point that you've kind of alerted the board to, really, which is it mirrors the you know, I'm on the National Climate Emergency Board for NHS Wales, and kind of the budgetary kind of limitations. It's a big constraint in terms of kind of the ambition that can actually be taken forward in this space, with the lack of kind of sustainable revenue and capital, actually, particularly, and that's particularly relevant, I think, for the wider NHS estate. But it's something that, from our perspective, that and I'm sure Claire has kind of updated on that we will take forward as part of the Building Our Future, because clearly the achievement of our targets in terms of decarb and some of the other strategic objectives that we've got in our long-term strategy are all about kind of, you know, prosecuting that decarb plan, aren't they? So yeah, just wanted to make that point. Thank you, Chair. Thank you, Marianne.
Thank you, Helen. No other comments. Thank you. We'll receive that report. Thank you very much, Marion. And last but by certainly no means least, the report from the local partnership forum. And I think, Helen, you were in the chair for the last meeting.
I was, yes, and yeah, one of my favourite meetings, to be honest. So yeah, not a lot to add to what's been put into the papers, really. Just, I think, to pick up on the point I think Andrew touched on earlier as our associate member of the board and co-chair, actually, of the local partnership forum with me. Just the collaboration that we have, and I think some of the results that we've had through the staff survey actually demonstrate the level of openness and collaboration that we have between kind of you know, our people and OD team operating on behalf of us as an organisation and the staff side, really. And yeah, just to commend that relationship, because you've got to actively manage these relationships, and there is a lot of attention paid to that and a lot of investment in terms of time there. And just to thank Andrew and Paul Evans, who are, you know, the backbone really in terms of the staff side representation on the local partnership forum. But I think also that we would reflect that we may want to look to see whether we get a bit more kind of staff side engagement into future LPF discussions. So we'll work on that with Andrew and Paul going forward, really, to make sure that we've got kind of, you know, perhaps a broader voice coming into the discussions, because we do have some really good discussions and work through some of the, you know, the changes in the organisation, particularly in the risks the organisation is facing. So yeah, just wanted to bring that to the board's attention. Thank you, Chair Deal.
Thank you, Helen. Thank you very much indeed. And again, we're asked to note that report. And again, I'm sure we're happy to do so. Okay, if we move then on, I know no other urgent business has been indicated to me. So if I move on to the last item, the date of the next meeting is Thursday, the 26th of September. If I can remind people that later today we have the AGM at 3 p.m. Anyone who is observing this meeting, if you wish to join the AGM, you can find the link on our website. But before I bring the meeting to a close, I would like to, it's always sort of a degree of sorrow and indeed pleasure in terms of wishing someone the best for the future. But the sorrow is that Sarah Jane this is her last meeting of the board. She won't be with us for the September meeting. She'll be taking that leave that's owed to her. I should think that's what the issue is, isn't it, Sarah, in terms of getting it in before you leave. Sarah's moving on to pastures new, and I'll ask her in a moment if she to tell us a little bit about where she's going. Thank you all for all your efforts, Sarah Jane, over the past few years. You've taken a new organisation a long way in the people and OD space. We know there's always more to do. There always is, but you've left us in a very good place as you move on to your the next part of your career. So thank you very much, Diolch yn fawr, Sarah, for everything you've done for DHCW. I don't know if you want to go on, Sarah. Sarah Jane.
Thank you very much, Chair. Yeah, thank you for your kind words and also the kind words of colleagues on the call and across the broader organisation and indeed my team. It is a great opportunity, but I have thoroughly enjoyed working here, thoroughly enjoyed working with Helen and colleagues. It's been a fantastic opportunity, and I think I came in at a really good time and we've achieved a great deal. So I will help, obviously, Helen and colleagues get a good successor, so you have that longevity for the future, really, with all the endeavours that we've started and are driving forward. So yeah, it is with sorrow. I am really happy with my new role. I'm going to central government in Whitehall in England, so it's where I started my career. So it feels like the right thing to do, and it's a great opportunity. But I've really enjoyed working here. I really miss everybody very much indeed. So thank you very much.
Thank you, Sarah Jane, and we wish you all the best for the future. Okay, that's bring the meeting to close, and obviously I'll see everyone here again at 3 o'clock. Till then, thank you. Bye.